Singh. Dr. Singh is FEI's first glaucoma fellow who is completing her training this month at Medical College in India before completing her ophthalmology residency at LLRM Medical College, also in India. She originally came to us in 2024 and completed a pediatric ophthalmology fellowship. She liked Rochester so much that she decided to pursue her glaucoma training here. And congratulations to the Eye Institute's first double fellow. Today, she will be presenting a topic, medical and surgical treatment in glaucoma. Please join me in welcoming Dr. Singh.
Hi, everyone. Can you hear me? Okay, great. It's really a pleasure to be here with all of you after spending 2 years. And I have learned a lot from all of you in the clinic, in the OR, and it was an amazing journey. So today I'm going to talk about medical and surgical treatment of glaucoma. And before jumping to the topic straight, I would just talk about glaucoma at first. What is glaucoma and what are different types of glaucoma? So it is the leading cause of irreversible blindness worldwide, we all know, and more than 80 million people are affected globally. Now, what is glaucoma? So glaucoma is chronic progressive optic neuropathy with or without rise in intraocular pressure. So the pressure can be raised or not raised, and visual field changes. Let's look at some of the risk factors. Elevated intraocular pressure, it is the most important and modifiable risk factor. This is the only factor that we can control. Age, family history, race, thin cornea, myopia, eye injury, diabetes, steroid use. And this is important knowing these factors because when you are in clinic with the patient, you can always ask about these factors during history taking. And I've seen that you all do that. I mean, when the patient comes to us, it's already elicited in the patient's history, whether the patient has any family history of glaucoma or steroid use, number of surgeries, what surgeries were done. And these are really important things. Coming to the types of glaucoma. So there are 2 types of glaucoma: open angle and angle closure glaucoma, and secondary glaucoma. I can't see open angle there. I don't know. It was there in my slide anyways. So yeah. Can I minimize this thing? Oh yeah, sorry. So open angle is primary open angle, which is usually associated with raised intraocular pressure or borderline high. Normal tension is where the pressure is normal, but yet the patient has glaucoma, and there are several factors for that. And the angle closure, when the angle is closed. Then we have secondary glaucomas and different types of secondary glaucomas like uveitis, neovascular, traumatic, steroid-induced, and these can further be open or closed. And pediatric glaucoma. Now, coming to open angle glaucoma. So what is open angle glaucoma? First of all, it is the most common clinical entity that we see in clinic among all kinds of glaucoma, that the patient has open angle. And so by open angle, we mean that the angle between the iris and cornea is open. Usually it is painless and there are no acute vision changes. So here in this picture, we can very much see what happens is that when the aqueous humor, which is secreted from this ciliary body, it circulates through the posterior chamber and then to the anterior chamber. Once it reaches the anterior chamber, it passes through this drainage pathway, which is called trabecular meshwork and Schlemm's canal, and then to other collector channels. This is how the drainage pathway is. So in open angle, this angle between the cornea and the iris is open, and there is no blockage to the fluid flow. And that is why it is painless. So even with advanced retinal neuron loss, patient may be without any symptoms. Now let's look at the angle closure glaucoma. It requires immediate attention. There's closed or narrow angle between the iris and the cornea. So if you look at the picture, the angle between the cornea and the iris is very narrow. And with advanced age, as the lens increases in size, the iris comes in close contact with the lens, and there occurs posterior pooling of the fluid in the posterior chamber. And ultimately, it pushes the iris totally in contact with the cornea and thus blocks this trabecular meshwork pathway through which the fluid exits. And that causes an acute attack of angle closure glaucoma. It is most common in Asian population. And there are noticeable symptoms like, this is like what you can see when you are on any emergency duty, and the patient may present with blurring of vision, halos due to corneal edema. There's a mid-dilated pupil, and the patient might be complaining of severe pain with injection. So this is how, if you see a patient in any of the waiting area and they developed an acute attack, you can make out that the pupil is not reacting. There is a blurring of vision, corneal edema, and pain. Now, let's look at some of the diagnostic workups we do for glaucoma. And you all do all the time in the glaucoma clinics, visual acuity, tonometry, pachymetry, slit lamp, gonioscopy, and fundus. And glaucoma imaging. So glaucoma imaging is a very important part of glaucoma management, because it not only screens the patient for glaucoma, but also helps us in following the treatment plan, because we can see the progression in visual field on OCT. And glaucoma imaging mainly comprises of two tests we do: optical coherence tomography and visual field. And this is the part where we need ophthalmic technicians so much, and we just can't survive without all of your helps. So now, what is OCT? It takes highly detailed cross-sectional image of the optic nerve in retina and measures the thickness of the retinal nerve fiber and detects actual changes even before they are evident on visual field. Coming to visual field, we use Humphrey visual field analyzer most commonly, and it detects any localized or diffuse spots of vision in the field of vision. Now let's jump to the main part, that is the treatment. So let's look at some of the treatment principles. The main principle is to bring down the intraocular pressure, because this is the only modifiable risk factor. We cannot control age, we cannot control family history or any other genetic factors, but we can control pressure. And so here is a stepwise approach that works. So the first line treatment for any glaucoma is prescription eye drops. We can do laser treatment for some specific form of glaucomas. And the surgical option is in the very advanced cases when it is not responding to maximal eye drop therapy or to the laser treatments. So what are the types of eye drops? We have prostaglandin analogs, carbonic anhydrase inhibitors, beta blockers, Rho kinase inhibitors, and alpha agonist. There are basically two mechanisms how these eye drops control the pressure. The first one is that it increases the fluid drainage from the eye. And among this class comes the prostaglandin analog, pilocarpine, and the third one is, I'll go through the slides later. So it increases the fluid drainage from the eye, and prostaglandin analogs are usually the most effective first line topical drugs that we use. They are latanoprost, which comes by the name of Xalatin, travoprost, Travatin G, bimatoprost, Lumigan, and tafluprost Zyopton. This has a turquoise or teal cap. And this is very important to know because sometimes the patient is not able to give any history about which eye drop they are using because they have dementia and they have other issues. So the ophthalmic technicians usually, or any healthcare provider, doctor, residents, they can take the history and mention which color cap eye drop they're using. Side effect is iris pigmentation and eyelash growth. Second is pilocarpine, that also increases the fluid drainage. It is not used frequently, but we use it before laser treatments as it constricts the pupil and helps in the laser process. It is also used as a therapeutic treatment for angle closure glaucoma when there's an acute attack of angle closure glaucoma. And Rho kinase inhibitor, Ropressa. Some of the side effects. So Ropressa generally most commonly presents with redness of eye. Second mechanism is the eye drops that decrease the aqueous humor production or the fluid buildup in the eye. These include carbonic anhydrase inhibitors, beta blockers, and alpha agonist. Can anyone here participate whether and answer some questions if I ask? So which class is timolol? Does anyone know about it? Wow, that's great. You guys know everything. All right. Okay. So beta blocker is timolol. It is prescribed once or twice daily. Some of the side effects: asthma, heart block, depression, glucose intolerance. Alpha agonist is brimonidine, prescribed 3 times daily. Side effect: ocular allergy, sedation, and it is contraindicated in children. This is the eye drop which causes maximum allergy. So most of the patients after a few years of using brimonidine present with redness of eyes and lid edema. And I mean, you can make out that they might be using brimonidine. Then the third one is carbonic anhydrase inhibitor, which is mostly dorzolamide and brinzolamide. Prescribed 3 times daily. Side effects: eye discomfort, metallic taste, and allergic reactions. There are also some fixed combination eye drops that are available. Like latanoprost plus Ropressa is Rocklatan, dorzolamide plus timolol is Cosap, brimonidine plus timolol is Combigan, and brimonidine plus brinzolamide is Sinbrinza. And these have the advantages of better convenience and effectiveness. So we do not prescribe oral medicines regularly, but if there is sudden rise in intraocular pressure that cannot be controlled by eye drops, then we give acetazolamide. And this is administered only for short period to bring down the intraocular pressure. Now coming to the laser treatment. So most commonly, the lasers that we use right now in glaucoma procedure, in glaucoma, is selective laser trabeculoplasty or SLT, peripheral iridotomy, and cyclophotocoagulation. Cyclophotocoagulation or CPC, we use it when there is end-stage glaucoma, patient has poor visual potential, and we don't want to do any invasive surgery. Now coming to selective laser trabeculoplasty, and this is another area or treatment plan where the ophthalmic technicians play a great role. So these are quick, safe, effective, and in-office procedures. And how it works. So it uses short pulses of double Nd:YAG laser to target selective tissue called trabecular meshwork, responsible for drainage without causing damage to surrounding structures. And who are the candidates? Can anyone tell here whether it's used in open angle glaucoma or angle closure glaucoma?
Open.
Okay, yeah, most of you are right. So it's used in open angle glaucoma. It lowers intraocular pressure by 30%.
Wrong one.
So if you look at this picture here, this is the trabecular meshwork, and the laser targets the TM selectively. So there's no damage to the surrounding tissue. So it is very safe and effective. So when we do it, patients of open angle glaucoma, as most of you mentioned, it is also used as first line in ocular hypertension. So ocular hypertension is characterized by high IOP with no evidence of damage to optic nerve. So the pressure is high, but the damage has not yet begun. And there is no evidence of damage in the visual field or OCT. But if we cannot leave the patient like that, we have to treat it, we have to bring down the pressure. We can wait if the pressure is like till 24 and 25. But if it goes beyond that, then we have to start some eye drop, or we can do an SLT also. As an add-on to 1 to 2 eye drops, when intraocular pressure is still not controlled and poor tolerance to drops. So some of the patients have this very poor allergic conjunctivitis because all the glaucoma eye drops, they cause some kind of allergy. So in those patients, we can offer SLT. They last for minimum 6 months to 4 to 5 years, and they can be repeated. That is why sometimes we have to repeat the SLT. Some of the questions that the patient might ask you just after the procedure, and you can answer them. Can we drive or resume work immediately? Yes. A short course of topical steroid is given post-laser to control the inflammation, and they are cost-effective. Now, the next laser that we do commonly is peripheral iridotomy. This is also an in-office procedure in which a tiny hole is created in the iris by laser energy, and this allows fluid to drain from the eye. So who should get it done? Excellent. See, you guys are so good and smart. So coming to the PI, how it works. So it creates a hole and in the iris so that when there's an acute attack of angle closure glaucoma, there is a pathway for drainage of the fluid. So there are like two indications where we use it. One is we can use in a suspect. We call them angle closure suspect. Those patients who have narrow angle, but yet the pressure is not raised, and they don't have any feature of glaucoma. They just anatomically they have narrow angles, and they are suspect. So, but we often think that they might end up in kind of acute attack of glaucoma, so we do it prophylactically. And the second one is when there is an angle closure glaucoma, when there's an acute attack of angle closure glaucoma, after we bring down the IOP with the eye drops like beta blockers or the oral medicines, then we do the pilocarpine because it doesn't work immediately. If the pressure is high, we cannot do laser immediately. We have to bring down the pressure first and then do a laser because there is ischemia of the iris muscles. So it won't work. So some of the complication after the laser, this is very interesting because most of the time the patient will ask you when you are with the patient in the laser room, they ask you, is there going to be any complication, any bleeding, and things like that. So the complications are very minimal. There can be some temporary blurriness, which will go away. There can be a temporary spike in intraocular pressure, which can be lowered by pressure lowering drops. And sometimes there can be closure of the iridotomy hole, and a repeat procedure could be offered. We also give a short course of topical steroids to control the inflammation post-laser. So role of ophthalmic technicians during laser procedure. So pre-procedure, what is the role? Let's see. Review the medical history and check intraocular pressure before laser. Preoperative drops. So what are the preoperative drops we give during before SLT and PI?
Pilocarpine. Durdolomite.
Pilocarpine is good, and
Big top.
Or Vermont.
Brimonidine.
Yeah, right. Brimonidine or apraclonidine, which is a shorter acting drop. It's the same as brimonidine, but it has shorter course of action. So we give it before laser. And we also give paracaine to numb the eye. So pilocarpine to constrict the pupil and help the process, apraclonidine to reduce the intraocular pressure. Positioning the patient during laser procedure. And do you guys know the lenses? Which lens do we use for SLT and which one do we use for PI? So we use Latina lens for SLT and Abraham lenses for PI. Some of other role that you can play during laser process, adjust the machine settings as per the requirement. Post-procedure, lens cleanup, switching off the laser machine, IOP measurement after the procedure, instruct the patient regarding the post-operative eye drops and follow-up. Now we are done with the medicine, we are done with the laser. Let's talk about the surgical options, which is the last resort when the glaucoma is not controlled with both laser and the eye drops. So what are the different glaucoma surgeries? We have trabeculectomy or TRAP, tube shunt, and MIGS, which is a recent advance in glaucoma surgery. And they're called minimally invasive glaucoma surgery. And usually we prescribe the type of procedure depending on the type and severity of glaucoma. So first, let's talk about the MIGS or minimally invasive glaucoma surgery. So who are the candidates? Anyone here? Okay. So we do MIGS when the patient has early to mild glaucoma and moderate glaucoma. So these are like minimally invasive, and so their effect of lowering the pressure is also limited. So we do in early glaucoma. They can be, some of the advantages are they can be combined with cataract surgery, and a single procedure can treat both cataract and glaucoma. Tiny incision and higher safety profile. So these are some of the devices that are available and are commonly used in the OR. We use it here also at Flom. These are micro stents, the eye stent and hydrus. And so this is the eye stent. So this is a small device that is actually implanted in the trabecular meshwork. This is the trabecular meshwork. So during the phaco surgery, after we are done with the phaco, through the same incision, we can implant this device in the TM. Hydrus is also a similar device which is implanted. Then there is the Zen-Zel stent, which we can do in more severe form of glaucoma. And this is a tube, small collagenous tube that is implanted in the anterior chamber through a hole in the sclera. And this is a beautiful view where a gonioscope is placed intraoperatively on the patient eye. And this is the trabecular meshwork. In here, we can implant a device, or there are some devices which we don't implant, like a Kahook dual blade or Omni. And these are like some kind of stents with just, we have to just insert and take it out so that it opens up the channel. So these are like microscopic devices to bypass the blockage, enhance the flow. Omni is also a device that flushes and opens the eye's natural drainage system. Now coming to the next surgery, or trabeculectomy. So what is trabeculectomy? Trabeculectomy is a filtering surgery. And this is a more invasive surgery in comparison to MIGS. And we do it in advanced or severe glaucoma. So here, we create a small scleral flap, a partial thickness scleral flap. And we create a hole over here so that the fluid from the eye is drained into the subconjunctival space. So a scleral fistula is created with overlying conjunctiva, and this forms the bleb. This surgery creates a space for fluid drainage. Next is tubes. This is also a more invasive surgery, or we can say conventional surgery. And there are two types of tubes. One is Emmett valve and another is bare valve. So this is what a tube looks like. So there is a plate which is actually sutured to the sclera. After we open the conjunctiva, we suture it to the sclera. There are two tiny holes here, and we pass the suture and suture it. And it has a tube part, which we introduce through a small incision in the sclera so that it is inside the anterior chamber. So the fluid is drained through this tube to the outside space. Okay, 2 minutes, sorry. So a tube is inserted in eye to drain excess fluid to lower the intraocular pressure. And this is what a tube looks like. We can see that. So it is done in severe glaucoma, not responding to medicines and laser treatment. Some of the complication of traps and tubes: hypotony, choroidal effusions, shallow anterior chamber, tube erosion, blood leak, blood infection. So hypotony is like when your pressure is high and you do these surgeries and the pressure suddenly gets lowered, and that is called like the pressure sometimes it's less than 6. When pressure is less than 6, we call that hypotony. And these are some of the complications that can occur because of the hypotony, like the choroidal effusion. They can be also shallow anterior chamber because of excess filtration. Your AC can get shallow. Coming to the post-operative care. So whenever there's a patient who has undergone a glaucoma surgery, what are the things you can do? You can do a visual acuity, intraocular pressure, slit lamp examination, of course, the physician will do. Educate the patient about the eye drops, shield use, and active restriction. Some of the post-operative warning sign where, again, you can play a great role as an ophthalmic technician, like if the patient who has undergone any glaucoma surgery and presents the next day with sudden vision loss or severe pain, red eye, then always alert the provider about it. Some of the roles of the ophthalmic technician in glaucoma: act as a bridge between patient and glaucoma provider in history taking, visual acuity, measurements, IOP, visual fields, preparation of the patient in the preoperatively, just now as I mentioned, for laser, monitoring post-op patient, education, documentation. And one of the most important thing is about the medication adherence pattern. Because some of the patients are not putting the eye drop because they find it very difficult to put the eye drops. So you can always show them or demonstrate them how to put eye drops. And also to identify the barriers, why they are not putting the eye drops. Some of them do not have insurance or there are other things. So you can always inform the provider about it. And yeah, thank you.
Well, our next speaker is Dr. Wen Hu, right here. Dr. Hu is an assistant professor of ophthalmology and part of our uveitis service here at FLOM. She splits her clinical time between treating both adults and children with uveitis. She also is the associate director of our residency program. She received her medical training at Harvard University, where she also completed a doctorate in neuroscience. She remained at Harvard to complete her ophthalmology residency and went on to complete a uveitis fellowship at the Moran Eye Center and as a HED ophthalmic fellow. She also is interested in research and performs clinical trials related to uveitis. Please give a warm welcome as she provides a clinical approach to uveitis.
It's been a couple years since I've given this talk, and I think there are a lot of new faces in the audience. So I just want to get a sense of who here works up patients. You know, they come in and you're the person doing the visual acuity, the pressure. Okay. Who here is doing testing? All right. Who here, maybe, do we have any nurses here or other roles? Anything I'm missing? Oh, research, yes. My team back there. All right, so this is geared more towards the clinicians, the people who are patient facing. And I like to say the subtitle of this talk is, why does she ask so many questions? Why does she see the patient undilated and dilated? Why does she get so many tests? And why is she always running behind? And I hope that by the end of this talk, I will have answered some of those questions for you. So first question for all of you, what is uveitis? All right, I heard inflammation, I heard uvea. You are already steps ahead of probably every single person who graduated medical school because most doctors don't know what uvea or uveitis is. All right, so my next question is, what is uvea? Oh, somebody here knows. Iris ciliary body choroid, yes. All right, so technically that is the technical definition of uvea. But in the world of uveitis, we kind of think any itis of the eyeball is uveitis. And that's okay. But the way I think about it as a uveitis specialist is, okay, where exactly is the itis? So my first job for any patient is to figure out where is your inflammation. And broadly speaking, we talk about anterior uveitis, which is in the anterior chamber, mostly inflammation of the iris, intermediate uveitis, inflammation of the ciliary body, and vitreous, so vitritis, and then posterior uveitis in the back of the eye, your retina, choroid. But as you know, this doesn't cover scleritis, inflammation of the sclera, or orbital myositis, inflammation of your muscles, your extraocular muscles. Let's talk about each of these individually. So anterior uveitis, you may have also heard us or Dr. Shafera talk about iritis or iridocyclitis, anterior cyclitis. Those are all names for the same thing. We're very bad at being uniform in our descriptions. And so this is a group, the standard uveitis nomenclature working group, that is really trying to make things more standardized for you. But hallmarks that you'll see of anterior uveitis are keratic precipitates. You see on the endothelium, the inside surface of the cornea, all those little white, grayish deposits, those are keratic precipitates. What about this? Yes, posterior synechiae. I get lots and lots of patients with funky pupils, and you could just say irregular, it's okay. Intermediate uveitis is primarily inflammation in the vitreous. And so this is a more severe case. If you're looking with the indirect ophthalmoscope, you'll see these little white balls, and they have a cute name, snowballs. But really, that's just clumps of inflammatory cells. And then posterior uveitis typically refers to inflammation of the retina or choroid. So here's a fundus photo of the back of the eye. And I don't know if you can appreciate right along that inferior arcade, do you see something that's like a little less orange and a little more yellow than looks like a normal eyeball? So this is early. And then this is what happens when this choroiditis progresses. And you can tell that it's deep because it's under all the blood vessels. You can see the retina vessels coursing over. And then this is what the eye looks like when it's scarred down. So all that active inflammation that looked kind of yellowish, orangish goes away, and you're just left with the retinal pigment epithelium hyperpigmentation. Here's another patient with a different type of choroiditis, and you can see there's so many different things going on. She's had multiple flares in the past, but you can see the hyperpigmented scars. This really white spot right over here, infranasally in this left eye, that's actually so much inflammation that you're now seeing through to the underside of the sclera. You're almost seeing out of the eye. And then there's a little fuzzy patch along the superior arcade. That's the active inflammation. So you can see all the different stages of inflammation here. And this is an example of retinitis, so inflammation in the retina. It looks a little more white. It's a little more anterior. And then this is actually necrotic retina, unfortunately. And this is what we would call acute retinal necrosis from a herpetic infection of the eye. There are a few other things that are commonly associated. So those are your classic uveitis. And then, oh, I forgot to mention that panuveitis, you have to have inflammation in all these areas. So if you see patients with panuveitis, it just means inflammation everywhere. Patients with any of those inflammations can also develop cystoid macular edema, swelling in your retina and your macula. They can get optic nerve edema. They can get retinal vasculitis. And so you see the fluorescein dye leaking out of the periphery, all around the periphery of this retina. And then you can actually see there's two areas along the superior arcades. That's different leaking. There's so many types of leaking. This is neovascularization, so new abnormal blood vessels that are prone to leaking even more than the other vessels that are already leaking. And then this is a patient who developed occlusive retinal vasculitis. So if you can see, the blood vessels are all sclerotic and white, and there's actually no perfusion going to her retina. Can you see my pointer here? This little area right here is her only remaining normal retina in this eye. And so the reason I see patients undilated and dilated is because, one, when they're undilated, I can actually see, is there inflammation in the anterior chamber? Sometimes if you dilate, you get pigment, and then that's mistaken as anterior uveitis. Two, I'm looking for all the places where there are inflammation. And then three, the reason I get all the imaging is because sometimes I can't actually see the inflammation. So I'll give you a couple examples. This is a patient who had bad HLA-B27 anterior uveitis, and you can see he's completely sneaked down his pupil here, and there's all this pigment overlying his pupil. And the only way for me to look into that eye, instead of this nice, big, beautiful dilation that I see in my general ophthalmology clinic, is I can look through to his retina right here. But remarkably, you could get an optos photo. And this is so much more of his retina that I could not see. This is that patient I showed you just a couple of slides ago with all that leakage in her retina. You would think her eye looks really bad. This is the picture of her eye. If you did not look very, very closely, and sorry, she has a little bit of a cataract here that's blocking it, you would think this is like a pretty normal retina, and you would never have guessed that this is actually what the fluorescein dye shows. So imaging, super, super helpful. Principle number 2 for patients who walk into my clinic is I don't assume anything, and I ask them everything. And mainly because I'm thinking about all these weird things. By the time patients get to me, they've probably seen at least 2 or 3 other eye doctors. Sometimes they've seen another uveitis specialist or a retina specialist. And so I'm dealing with the rarest of the rare things. And so I want to know, have you gone anywhere weird, international travel recently? Do you have weird exposures? Do you have weird pets? Do you have any tattoos? Do they swell up on you? I'll show you an example of that. Have you ever been in jail, or have you ever used recreational drugs? Do you have sexually transmitted infections? Some of these things track together, and we'll talk about that. Those of you who've worked with me in my clinic know the patients are all usually very confused and concerned about why their eye doctor is asking them these questions. You can help me by reassuring them that she asks a lot of questions. Principle number 2, assume nothing, ask everything, is because a lot of uveitis tracks with systemic disease. So they have inflammation in the eyes, and if it is an autoimmune uveitis, often they have inflammation elsewhere in their body. So I'm trying to figure out, do you have uveitis that's just your eyes? Or do you have an inflammatory arthritis that I should send you to a rheumatologist? Do you have bloody stools and I need to send you to a gastroenterologist because ulcerative colitis tracks with certain uveitis? Do you have weird skin lesions that we could biopsy and help diagnose what's going on? And the reason this all matters and why I ask all these questions is because once you start to pick the little pieces, put the pieces together, you can narrow down, okay, what is this? Is this a chronic or acute? Is this unilateral or bilateral? Where is the inflammation? Who is your host? Are they immunocompetent? Are they immunocompromised? Are they a kid? Are they an adult? And then sort of arrive at a diagnosis that hopefully answers the question for the patient of why do I have what I have? Busy slide, but I just want to show you that sarcoidosis is an inflammatory disease of your entire body, but classically affects your lungs and your skin. But it can affect your eyes as well, and it can do anything in the eyes. So you see it falls under anterior, intermediate, posterior, pan uveitis. And here are some examples of sarcoidosis. You get these, what they call mutton fat keratic precipitates. They look big and fluffy and juicy and fatty, I guess. I don't know. I've never seen mutton fat. But this is what it looks like if you were to look at it straight on. You can also see in this picture that there are some nodules on this iris, that this iris is not completely normal. And those are inflammatory nodules. You can get inflammation in the choroid, a choroiditis. And so on ICG, all these dark spots where the ICG dye is not filling are actually all choroidal lesions. This is what it looks like when you've scarred down a little bit more. So multifocal choroiditis. And then the reason sarcoidosis, we always ask about tattoos, is often they track together. Tattoo-associated uveitis and sarcoidosis, we think, are closely related, and that it's some form of inflammation potentially to pigment. And so this is an example of elevated tattoos that I'm always asking people about, because that can help guide our diagnosis here. The other thing that can do anything in uveitis is syphilis. And so that's why I ask everybody, have you ever had a sexually transmitted infection? And even if they tell me they haven't, they're getting a syphilis test regardless. And it's because it can hide. That's why when you're pregnant, they make you test for syphilis multiple times. So syphilis in the eyes can do some very bad things. This is a patient who had undiagnosed syphilis for, we think, probably 10 years. He was treated for just recurrent anterior uveitis. And this is what the eye ended up. The iris is atrophic. The pupil is completely scarred down. There's a thick fibrinous membrane over this eye. He ended up going into Iris Bombay. We had to laser him. He kept closing. I had to take out the lens. I couldn't put in a lens. And he, in the back of the eye, he basically had a central retinal artery occlusion. So he has no vision in this eye. This is a patient who I saw for intermediate uveitis. We did an entire workup. We didn't find anything. We treated her. She got better. A few years later, she came back with new intermediate uveitis. And it was weird. It didn't look the same. And we repeated a syphilis test and she was negative. And now she's positive. And she was not happy about it because she was monogamous. So here are some other things we have to deal with in clinic. This is a patient with syphilis. And if you look in the fundus photo, you think, okay, maybe this area looks a little abnormal. Maybe it's less of an orangish glow here. But when you get the autofluorescence, you can see that actually all of this area that's whiter, that's all abnormal retina. That's all areas that have been impacted by syphilitic retinitis. And then here's another patient who had a very classic, we call this placoid syphilis, where it looks like you have just a big plaque of patch of something. And if you're familiar with OCT maculas, they have lost all of their ellipsoid zone here. And unfortunately, this patient refused to get treated. And so shows up 3 years later. This is what the eye looks like. And it wasn't even his eye. He lost vision in this eye, and it wasn't even his eye that brought him back. It was because he had such late stage syphilis that he developed degradation of his spinal cord and he could not walk. And that's when he decided to come back in. On that note, principle number 3 in uveitis clinic is to always rule out an infection. We sort of think broadly. You can get inflammation. I think the misnomer, you think itis, it must be inflammatory. And by inflammatory, it must be autoimmune. Lots of other things can give you inflammation. So infection is the big thing we worry about because infection you treat very differently than autoimmune inflammation. And there are some masquerades as well that can also give you inflammation. So this is a patient who had cataract surgery and then had post-op rebound anterior uveitis, wasn't getting better. You know, you treat with drops, they get better, they taper off the drops, they were getting worse. And so they decide to do a steroid injection because this is just inflammation. no, this is endophthalmitis. This was an infection that you gave steroids and now you can no longer fight the infection. And this is the very sad referral note where they initially diagnosed pan-uveitis. And so they said subtenon's Kenalog triamcinolone steroid. And then that's the carryover from the previous plan. And now they're like, oh, actually, this is endophthalmitis. Now we have to talk about vitrectomy. Here's another sad case. This is a 46-year-old gentleman, no risk factors. He was seen for fevers and chills and at an urgent care. They thought he had a UTI, but they didn't get a urine culture. They put him on some antibiotics. He also had a red eye and he saw an eye doctor and they said, oh, this is anterior uveitis. Let me give you some eye drops. His vision went from 20/60 to hand motion in 2 days. And the answer that the eye doctor gave them was, oh, this is not getting better. Let's put you on some oral steroids. So he comes back a week later and vision is light perception and shows up here at Pflaum. And this is what the eye looks like. You have barely any view to the back, but I have enough of a view to know that there's something going on here that I do not know what it is and I do not like. And you get an ultrasound. And what is this? It's okay, I didn't know either, because then I called retina and Dr. K. Khan came to the rescue and said, this is a subretinal abscess. And so we sent him to the emergency department because we're like, where is this abscess coming from? He has no eye surgeries. It's not coming from the outside. It's coming from the inside. We sent him to the emergency department for an echocardiogram, ultrasound of his heart, CT scan of his chest, abdomen, pelvis, anywhere we could find something. Turns out he had liver abscesses from a Klebsiella infection. They confirmed it by aspirating one of those abscesses and treated him with IV antibiotics. He got better, but I think because of this abscess and how sort of advanced and late stage this was, and we probably didn't get great penetration with all the IV antibiotics, he then developed a scleritis, a necrotizing scleritis, then orbital cellulitis, and he ended up getting enucleated. So it was really sad because he's 46 and in a span of 2 weeks went from perfect vision to no vision. And this is the referral note that we received. So given the reasonable dose of steroids and not only no improvement, but definite worsening, now need to take into account more esoteric diagnoses, acute retinal necrosis, fungal, toxo, tuberculosis, syphilis, lymphoma, etc. I would say that my job is to rule out all of these things first, and then I can treat with whatever steroids I want, and everybody will be happy. Here's another patient, a young 30-something-year-old gentleman, no risk factors, who came in with just recurrent scleritis. He's a beekeeper, so it's kind of little weird exposures. We kept treating with steroids. He would get better, come off the steroids, he would get worse. So eventually he went on immunosuppression. And then he developed this weird funky nodule. It got aspirated. We didn't grow anything from it. This looks a little weird for just your run-of-the-mill scleritis. And then he comes back. And now this eye is necrotic. That brown, you know how before I said that white was you seeing from the inside out of the eye? This brown is there's no more sclera. You are now seeing the choroid and the retinal pigment epithelium. Sorry, maybe this talk shouldn't have been after lunch. So he got biopsied. We sent him for all sorts of sophisticated testing for infectious etiologies. This ended up being a bacillus infection. And this is what his eye looks like now. It's kind of stabilized, so to speak. I know, I heard that stabilized, yes. And so rule number 3 in my clinic is rule out infection, especially if treating with local or systemic steroids. So in summary, what I'm trying to do in my clinic, and I really appreciate all of your help in everything that you guys do, is I'm trying to identify where the inflammation is for these patients. That's why I dilate all the patients. That's why I get a lot of imaging. That's why I ask so many questions. I'm sending all these tests, including syphilis, TB, sarcoid, chest x-ray, and that's why I run very, very late. But I'm on time today. Thank you. Then
Okay, I have this question.
Yes.
What is a rocky cataract?
you have to come. You want to sneak in?
I'm like, what is she calling a rocky cataract?
You can sneak into the other presentation and watch my other harrowing surgical videos.
So we'll go ahead and get started. We have Dr. Surabhi Barwal is here, and she is one of our second-year residents. She hails from Wexford, Pennsylvania, in suburban Pittsburgh. Her undergraduate studies led her to Duke University, where she pursued her love of data science and engineering. She entered medical school at Emory University, where she leveraged her skill in computing to build machine learning and algorithms through a variety of projects related to medicine. And during her studies, she became a strong advocate in supporting access to medicine and championing medical rights for underrepresented patients. She hopes to pursue a career in academic medicine, and she recently presented research related to eye care access at ARVO, the big ophthalmology research conference in Denver. Please welcome her as she talks about an introduction to graft versus host disease. Dr. Barwal.
Whoa, thank you for having me. Sorry I'm late. This spot is brutal, like mid-afternoon, right before a break, in a room that is like 100 degrees maybe. I'm sorry. So I'll try to make this as interesting as possible. And I do want to thank the techs who came and requested this presentation. I want to preface with it, everyone was like, why are you presenting about something so specific at this conference? Like graft versus host disease is one disease and everyone else is doing something more general. A lot of times we think of dry eye and we're like, it's just dry eye. And I wanted to present this so you can see that dry eye actually has a very complex pathophysiology and it's not just dry eye, and patients really do suffer from these, symptoms from it. And here's kind of an extreme case. So this is a patient. He is, excellent. Bring the temperature down.
Yeah, someone told me someone suggested the lighting might make it cooler. Okay.
Yeah, I did too, actually. Okay. So we have a 68-year-old man here, and his ocular history, he previously had been seen for non-proliferative diabetic retinopathy. He had resolved choroidal hemorrhages. He had a history of a bilateral retinal detachment, history of a dislocated IOL. He was a very complex retina patient with hyperopia, presbyopia, and he had dry eye. But for relevant medical history, he, as the history would suggest, had diabetes with a high A1C, but he also had acute myeloid leukemia, and it was in remission. And he was status post allogenic stem cell transplant, which was life-saving for him. In 2021, the way he was diagnosed was that he went to his primary care doctor. He was having worsening fatigue, cough, and routine blood tests showed over 100,000 white blood cells. For people who aren't always looking at white blood cell counts, it should hover around 10. And 98% of those were blasts, which means that the body was actively producing white blood cells. In November of that year, he received a matched unrelated donor peripheral blood stem cell transplantation. He was started on tacrolimus, which is an immunosuppressive agent, and oral steroids. And then he developed tacrolimus-induced renal failure and was switched to another medicine. And then he developed high blood glucose levels and was started on a steroid-sparing agent, Jakafi. In December of that year, so only a few months later, he developed skin graft versus host disease. And we know from the studies that if you have graft versus host disease elsewhere, about 70 to 80% of those patients develop ocular symptoms. And then in May, a few months later, he developed oral graft versus host disease. And so he'd been having months of significant dry eye symptoms in both eyes. So this is a patient that you'll see come in again and again to clinic saying, I feel like there's something in my eyes and my vision is blurry. When I close my eyes, it gets better a little bit, but there's just no relief. So you tell them like, okay, let's just start using artificial tears. Put them in as often as you can get them. But it's been a year and he's been on Restasis, but he had allergic symptoms to Restasis. And then he was prescribed Xiidra, but his insurance didn't cover it. And so he's someone who's been suffering from these symptoms all of the time. And he ends up in our urgent care clinic, and this is like a complex exam. But his vision is suffering from this. He's 20/40, 2100. Now, some of this is the retina problems. And I just want to point out a few things on the exam. So we tend to see, patients with graft versus host disease, their exams are just like filled with writing. So I wanted to point out a few things. It really starts from the outside of the eye into the eye. So you have your lids and lashes. The margins of the lids are irregular. The lids are thick. The glands that are supposed to secrete the oil, it should look like olive oil. It looks more like coconut oil or toothpaste. He has thickening of both lids. So this isn't just one eye. His eye looks inflamed. So when you look at someone, like you are probably like looking at my eye right now and wondering why it's so red. It looks injected, it looks irritated. And then the cornea is really where we focus here because that's where the biggest impact on the vision is going to be. He has an epithelial defect. Is there an infiltrate? Is this infected? Is this just dry eye? You see PEEs in the chart a lot. These are truly, genuinely like punctate erosions. You can see them under the slit lamp from dry eye. And his tear breakup time is less than 3 seconds, where it should be more like 10 seconds. So he's really not keeping the tears on his eyes well. And as a result, it's like his eyes are turning into sandpaper that are being pushed up against with these thick, really inflamed lids. And then the rest of the exam is kind of more complicated because he has this complicated ocular retinal history. So when he came into clinic, he'd been treated for dry eye, but taking his whole medical history together, we diagnosed him with graft versus host disease. And some of that, and I will go into this later, graft versus host disease is not just, this is dry eye. There has to be a relevant history of someone having a transplant. And it's really graded by how much what you're seeing and how much that's affecting their day-to-day life. And we just recommended like aggressive lubrication. Let's get you into cornea as soon as possible. So he shows up to cornea 10 days later, and he's hand motion in that left eye. And we basically can't see into it. No one wants to touch it. No pressures. This is the kind of patient, a lot of the techs here are like, should I even touch this eye? And, what we find out is that he has a new 1 millimeter corneal perforation inferiorly in that eye. And so a patient who came in just 10 days prior, 2100, was saying his eyes were irritated. Sometimes we have this tendency to say, well, just lubricate it, it'll get better. It got worse. And so we glued his eye and put a bandage contact lens on. We started on antibiotic drops and we lowered his pressure because it had been elevated in the past. And we aggressively started to treat the graft versus host disease. So can we put him on pred drops 3 times a day? We're going to use Mugomist, Cystane lubricating ointment, artificial tears, olopatadine, which is used for allergy. And then he's already on the Jakafi and the sirolimus. We're trying to hit this as hard as we can. And the next few months are actually really just terrible outcomes for him. Despite interventions, his cornea begins to melt and we really can't undo it. So he had a patch graft. So he went to the operating room and got a patch graft. It leaked. He went back to the operating room and got another patch graft. It leaked. He went back to the operating room and got another patch graft. He then got a corneal transplant, but it continued to melt. And so his anterior chamber, you could see fibrin, his choroid started to detach. That eye is done. And so he lost his eye only a few months later. We had to remove it. And if you think about it, between these surgeries, we were also aggressively treating him. He was on Jakafi, he's on sirolimus, he's on topical medicine. So we're hitting him with everything. We have no clue what's causing this. So he's on PHMB, vancomycin, tobramycin, moxifloxacin. Those are all antimicrobials. He's on steroid drops, which are anti-inflammatory. He's on Tobradex ointment at night. And we even had him see the Uveitis service, and he's on oral prednisone. And then we often with these patients give a lot of medicines to help promote, basically prevent corneal breakdown or the destruction of collagen. So we give them vitamin C and oxycycline. And so he's now lost an eye from graft versus host disease. But the systemic treatment, it still goes on, and it has to do with a lot of other factors. As we mentioned before, he's previously gone into renal failure and hyperglycemia from his systemic treatment. So he was weaned off the Jakafi. We want to keep these patients on the fewest number of meds possible to keep them from rejecting their transplant. And then a year later, he actually ended up having a heart attack, and he underwent a coronary angiography. And in the aftermath of all of this inflammation, he actually developed a flare of his chronic graft versus host disease. So he had reduced vision, skin rash, itching, and all of his labs reflected the fact that the body wasn't doing very well. And so they restarted the Jakafi. And so we think about the other eye and a patient that really, he underwent this life-saving therapy, and his lifestyle has been completely impacted by this life-saving therapy. And so we want to save the other eye. Doxycycline, tacrolimus in the eye, preservative-free artificial tears, ointment at night, Miro ointment to help dehydrate the cornea, serum tears. This man is on every drop you can think of trying to keep this eye in place. And this is what it looks like. You can see this is like a slit beam through the cornea. And I see some of the techs who take these pictures for us. And this is a really good one where you can see if this line, you're following all the way down, this divot shows that the cornea is actually thinning centrally. This area is very weak. And all these little spots you see, those are the punctate epithelial erosions, the PEs you see on almost every chart. This is what it looks like when it's really bad. And you can tell the cornea looks inflamed, right? You don't have to be a cornea specialist to see this one is bad. So here's another one. You can kind of see that divot is actually really big. So areas of inflammation again. And unfortunately, actually this week he came perforated in this eye. And we've been working on trying to, he just underwent another patch graft in the OR. So when we stage ocular graft versus host disease, with any ocular condition, I think one of the reasons I chose ophthalmology is it's not just about the science and the medicine, it's also about the patient experience and how they're navigating their day-to-day lives. So graft versus host disease to me is such a great example of this because the science is so cool and so complicated, and the patients are really sick and they really rely on their vision as the one thing that really gets them through the day. And so it's from symptoms, we're talking about no symptoms to severe symptoms, like they are on bandage contact lenses all of the time. Like I have a patient who accidentally, something happened to his scleral contact lens and he was inpatient in the cancer center and he was just screaming in pain. He's like, can you just give me something to get me through the next scleral contact lens? The requirement of drops, are we talking is this low burden or really high burden? And then just other signs of basically day-to-day impact. And so I left some of these slides in. I'm not going to bore you with all the pathophysiology, but the eye is really complicated, and dry eye is not just about the tears themselves. It's about what's producing the tears and what the composition of those tears are. Are they getting to the right place? Are they staying in the right place? Are they filled with debris? And so just thinking about this, when you see a patient come in with dry eye, the lacrimal gland is really important. It is what produces the tears. So, we have to target the therapy according to where we think the dysfunction is. So are they just producing fewer tears because something is attacking the lacrimal gland? with the cornea, is it just that the cornea looks really bad? It's like sandpaper almost. It's thinning, it's getting infected, it's constantly ulcerating. It looks like it needs nutrients because there's blood vessels going all over the cornea. The conjunctiva, which I think sometimes we underestimate as really the first sign of like whether an eye is inflamed or not. You know, just looking at an eye, you can tell if someone is bothered by it, right? If it's red, if it's inflamed. And there's other things like we always pull open the lids and we look in the lids because people can form membranes and adhesions between the eyeball and the lids. And then lastly, I think the glands, the oil glands along the eyelid, we talk about them a lot, but I always tell patients who come in with dry eye, you know, you can put in as many tears as you want, but if your glands are not producing the right consistency of oil to get to where you need to go, then it doesn't matter how many tears you put in because your tears will be ineffective. They're a mix of oil and water, and the oil helps keep them on the eyes long enough. So I like to give people a descriptor like, hey, your oil glands, they look like they're being filled with toothpaste. You can literally under the slit lamp push on the oil gland and you see what looks like toothpaste come out of them. And I tell them, here are the different ways that you can, you know, deal with that. Warm compresses, like hygiene, we can do oral doxycycline for these patients. Some of you who work frequently in cornea clinic will see that in order to protect the anterior surface of the eye, sometimes we'll sew the eyelids together, either temporarily or permanently, just to save the eye. And so this is just more complicated that I probably can't explain at this exact moment in this heat. Pathophysiology, but really we're trying to find novel therapeutics that can target specific ways that the eye gets inflamed, and not just ocular graft versus host disease, but other forms of really pervasive dry eye. So, you know, some people get punctal plugs. Topical valsartan has been started to use in different trials. You know, for some of these patients we'll use bandaged contact lenses, low lenses. It's really a collaborative effort with, you know, ophthalmology, hematology, and oncology, and also optometry to get the best care possible for these patients. And so just to go back to this, like as complicated as the pathophysiology is, to me, I just kind of really try to, when I counsel patients on mild dry eye to really severe dry eye, try to focus on what do I actually think is malfunctioning here and how can we maximize what we do for this patient. And sometimes it is, let's just throw everything at it in the effort of protecting the eye. And so we do have treatment. When you see these patients in clinic, you'll see a lot of different things. So you'll be like, wow, the cornea looks really bad. There's like an epithelial defect, they have an ulcer, but why are they still wearing contact lenses? That's a really powerful way for us to protect the cornea against these like really corrosive lids. And also these patients are suffering in so many ways. It's great comfort for them. So I think of it as systemic. We really need help with the hematologist to do this. And then for local, you know, we can always throw a steroid at it. For tears, we can either increase the supply through artificial tears or decrease the outflow by putting in those punctal plugs. We can do warm compresses. Some studies show like flaxseed oil and fish oil supplementation. It's like the omega-3s can help promote that. Oral doxycycline is a great option. And then this is the last piece, the epithelial supplementation. So scleral contact lens, plus or minus, should we sew the eyelid together? Should we put an amniotic membrane on there? Or should we go for transplant, which we did for this patient? And then serum tears, which are sometimes very difficult to get because there's so much like care coordination, orchestration that goes into that. We really rely on collaboration with our coordinators to do that. And so thank you for your time. I'm happy to take questions.
Topical valsartan, like what's this?
It has to do with the HSP47 fibroblasts and the production of them, and it inhibits that pathway. I think it's really hard to get compounded here. We have tried to work with the pharmacy, not just valsartan, but losartan. So we don't actually do it here. Yeah.
Okay.
Yeah.
Dr. Planick has mentioned that, or has told patients that a certain degree of graft versus host disease is actually like a good thing because their prognosis is better overall. So I was wondering why that is, if that is true.
Yes. Okay. This has to do with, I was just actually thinking about this. I was like, I hope someone doesn't ask me this question because I don't know this. Because there's like different forms of organ rejection, and graft versus host disease has to do with like the fact that your graft is having like a robust uptake by the body, which you want. So you want a certain level of like robust uptake of the graft by the host. It's only when that balance is like shifted where that's a problem.
Yes.
Any other questions? Well, thank you so much for having me.
Okay, we're going to go ahead and get started. Okay, our next speaker is Dr. Ayat Animat, who is our pediatric ophthalmology fellow. Dr. Animat will remain in Rochester after matching to FEI's glaucoma fellowship under the direction of fellowship director Karen Allison, MD. Many of you know her. Let's see here. Here. Okay, there we are. Please welcome Dr. Animat as she talks about peepers, creepers, and tiny weepers.
Good afternoon, everyone. Is it working? Yeah. Good afternoon, everyone. Thank you for the nice introduction, Dr. Gargarinats. So let's get started. So thank you for joining today's session on vision screening and strabismus assessment in children. As ophthalmic technicians, you play a critical role in the detection of pediatric eye disorders. As you know, many of the vision problems in children can develop silently and get easily unnoticed until very late in the disease, where significant damage has already occurred, especially in amblyopia. And since the visual maturation usually develop during the first few years of life, specifically the 8 years, the most years that really matter, it's like in the beginning, like the first 1 year, second year. But we can, if we were able to address these abnormalities during this critical period of time, we will be able to improve, to address them, and we will be able to improve the overall child's visual development and overall quality of life. So let's get started. So this is, okay, I will keep moving. So this is how we like to see our pediatric patients in the clinic. We like to see them smiling, engaging, cooperative, but the reality is a little bit different. So, you know, like, as you know, like some of you have worked in the pediatric clinic and have noticed how can children be easily bored, lose interest, and sometimes they just like out of nowhere, they decide they don't want to participate in the examination anymore. And unfortunately, sometimes they may even feel frustrated and start crying. So the thing is, so our thing is to understand how to approach these situations and how to adapt our approach in dealing with them, and in order to be able to obtain a reliable and accurate assessment. So our learning objective is to realize the special aspects about conducting pediatric vision and strabismus examination, perform age-appropriate visual acuity assessment, perform and interpret the cover and cover test during the alignment check, and differentiate the basic patterns of strabismus. Now, regarding the pediatric exam challenges, the thing is, when we deal with the adults, it's different. Like adults are, like, you know, they're adults. But with kids, first of all, they have limited communication. They are anxious, they are fear, they are nonverbal, like especially when they are really young, like infants or toddlers, and some of the time they might be autistic. So first of all, our first challenge is limited communication. They can't speak for themselves most of the time, and the other thing is they have short attention span. Like kids can get easily distracted with the people in the room, with the noises around. So this is the second challenge that has to be addressed. The third thing is developmental differences. So the thing is, most of the time we are guided by the biological age of the child in order to choose the vision testing, but this can't be uniformly applied for all of the children that we see at the pediatric eye clinic. Sometimes children of the same chronological age, they behave differently. The cooperation, the level of cognitive ability is different. This can be related to just like variant of normal, you know, like not all the kids will achieve their developmental milestones at the same age. And on the other hand, there are also other neurological diseases that might be a limitation, like, you know, CP, global developmental delay. So we have to be mindful of these differences. And the other factor is environmental and cultural factors. When it comes to environmental factors, it's like, you know, kids who are being attending the preschool or like being engaged with parents and the being the people around them and play games like matching games and other stuff. Also, the language development. So all of these factors have a positive, like have an influence on how the kids behave during their visual testing and which test would work for them the best. Like a 3-year-old who sees very clearly, but she has never been introduced to like matching game, she will never be doing well on the Lia matching, or for an example. So we have to address these factors. Now, with regards to cultural factors, you know, we are strangers for them. They are like, they see us the first time in the clinic. And most of the parents, and this is like normal, parents, they always teach their kids like not to talk to strangers. So we are strangers. So that's why, you know, like when they come to the clinic, you have to establish a rapport with them, being a little bit playful, and try to break this boundary with the presence of the parents and with their permission, of course. So these factors should be taken in consideration, and these factors are the challenges that we face during pediatric eye exam. So now we are starting our examination. So when starting from the point we call the patient, and we have to start our observations for their visual behavior when they are walking through the hallway before they enter the clinic. This is very important. The other thing is, we always ask the parents or the guardian who is coming with the patient, like, what brings you here today? What is your concerns regarding the vision or visual problems in your child? And after we address these issues, we have to put a big smile on our face and start like the fun. One of my attendings once said that being a pediatric ophthalmologist is like being a performer, but our audience is the kids. So you have to bring creativity and energy and being playful with them during the exam. And actually, this is like the fun part, like, and very rewarding part with dealing with kids and being a provider for kids. Now, we always try to keep the child at ease. So if the child is like, doesn't want to leave his mom or his dad and they want to sit on their lap, leave them on their parent lap. And I remember one time in the clinic, one of the patients, she was like terrified to enter the room. So Dr. Geringer, he's one of our attendings at Flom, he asked like to examine the kid like in the waiting room. So sometimes like you have in the waiting room next to the clinic. So we did the vision exam and then we took the patient to the waiting room and continued our exam. So this is the thing. We break the rules when dealing with kids. And if we are testing the vision with their glasses on, if we are using the Snellen chart or like pictures on the screen, you have to make sure that the glasses are clean. Because like for you who have worked in the pediatric clinics, I don't know if I don't see Kelsey, probably because I'm not using my glasses. But Kelsey knows that we always, and they always know that we clean the glasses, like because they are bit scratched. So like we try to clean them before we test the vision. And always try to do monocular vision testing. Always, like we do like each eye individually, and we have to cover the eye under the glasses with a patch so they don't peek. Because kids, they are really smart and they can fool you. So be aware. And also another part, you have always to encourage the patient, especially in kids. Like sometimes they see the visual target, but they are like still like in their shell. So you have like to encourage them. Just guess it. Just try harder. So yeah. Now regarding the choosing of the visual acuity exam to be done, it is like it should be age appropriate visual acuity exam. When we see infants, we we address them just by blinking to light. At 6 weeks of age, we should expect that they will be able like to contact or like to do to be able to look at human faces and being able to eye contact with the humans. At 3 months of age, they should be able to do fixing and following, which is fixing and following for a toy or for the light or for the human face, like for your face. From 3 months to 2 years of age, we can use fixes and follows, but actually we try to like use something else, especially like after I would say, after 1 year of age, we try to use like CSM, central steady maintained. And so central steady maintained is basically, so I am the patient, okay? You will cover my eye and look at this eye. If it is central, in the center, so it's not going in or out, steady, there is no nystagmus, there is no jiggling of the eye movement, and maintained, when you remove the cover, the eye still takes fixation. It's not like moving in or out. So this is for CSM, and we should apply this for each eye individually, for this eye alone and for this eye alone, okay? And now with regards to preferential looking test and OKN, actually, we don't use them in the clinic, like we don't use them regularly in the clinic. Just for your knowledge, there is like preferential looking tests, which is basically based on the fact that children like to look at patterned visual stimuli rather than plain visual stimuli. So we will, on research purposes, most of the time, we will show them like these patterns, and we will see if the child is like moving his eyes or moving his head and being attracted by the presented visual stimuli. This is how we know if they are nonverbal or they are not cooperative that they are seeing. And we can make like a rough estimation based on the size or the frequency of the pattern, of the presented patterned stimulus, how much are they saying, okay? Now, with regards to the OKN or optokinetic nystagmus, I have a picture for that. I'll show it to you later. So it's basically like a drum, and it has these stripes, black and white, and we roll it and we will see how the eyes are moving. So if the child is tracking the movements of the drum will initiate a reflexive eye movements slowly in the direction of the moving drum and like quickly on the opposite direction. So anyway, we just like look at the child and observing his eyes if they are tracking. But these, we don't use them in the like every day in the clinic. Like we just know, like just for your information. Okay, and I would say sometimes we use it, but it's not quite often. And now with regards to 2 to 5 years of age, we like to use LN pictures, the HOTV, Leah symbols. It's like matching games. And sometimes, like most of the time, kids, they are really good at naming letters if they are especially at kindergarten or preschool. So they will know like this is S, this is V, and they can like name the letter. So we can use Snellen eye chart in 5 or 4 years old according to the, like sometimes even 5 years old can do that. So it depends on their level of development, cognitively, I would say. Now, these are the Leah gratings. These are like the gratings. This is like the test that we use in the preferential looking test. And these are Leah pictures. Here is Ellen pictures and HOTV. It's a matching game. We ask them like, what do you see here? And he will like match it. And here is the OKN. It's like a rotating drum. And we will observe the movement of the eyes of the child. Now, special considerations. We mentioned that we have to address each eye separately. We mentioned that we have, the other thing that we have to address is when we present the Snellen eye chart for them, we have to present the full line. You can't use like single optotype. You have to present the full line or the crowding bars, like use the single optotype with the crowding bars. The idea behind this is in order to be able to detect amblyopia or the so-called lazy eye, if we didn't use the full line or the crowding bars, we are going to overestimate the visual acuity of the child. So in order to overcome this problem, we have to use the full line. Like you have to present the full line of the Snellen eye chart and ask the kids to name the letter or the crowding bars. So the amblyopia or the lazy eye is reduced best corrected visual acuity in one or both eyes that is not related to structural anomaly of the eye, and this happens during the visual development early on in life. When we are talking about monocular amblyopia, the definition is more than two lines, like 2 lines or more difference in visual acuity. Let's say one eye is seeing 20/20 and the other eye is seeing 20/40. This is like the other eye is amblyopic. This is amblyopia. And we address amblyopia, as you know, with patching. We will, depends on the level of amblyopia, whether it's mild, moderate, severe, we address it by patching. The difference is in the number of hours, whether it's 2 hours, 4 hours, 6 hours, respectively. And now, when you are examining the kid, how to know if this is like normal visual acuity for this kid or not? Roughly, I would say a kid with 3 years old, he should be able to see like 20/50 or better. A child with 4 years old, they should be able to see 20/40 or better. From age 5 or more, 20/30 is considered normal. Anything below that, this is abnormal. And as I said earlier, there should be no difference more than 1 line between both eyes. The other thing that should be taken in consideration is nystagmus, which is jiggling movement of the eyes. We can't do like patching when we examine the kids with nystagmus to check their visual acuity. You have to do fogging, like you have to put like +5, +6, +7 over one of the eyes and look at, examine the other eye. This is because if we did patching for the kids with nystagmus, this will worsen the nystagmus and it will worsen it will falsely worsen the visual acuity. So kids with nystagmus, we don't patch, we do use fogging. Okay?
Can you explain what the fogging is?
Yes, so the fogging is you put like simply on a trial frame, you put +5 lenses over, let's say we are examining the right eye. So we will put +5 or more lens over the left eye in a trial frame. So it acts like a patch, but not physical patching. It's like optical. Okay? Is that clear? Clear? Okay. So we are finished with the vision part. Now we will start the alignment check. So for the alignment check, there are like many different ways for the alignment check. It's cover and cover test, alternate cover and cover test, Krimsky, and Hirschsprung pin light testing. So the most formal way and the most accurate way is cover and cover test and alternate cover and cover testing. We use Krimsky and Hirschsprung pin light testing in certain conditions. We will talk about that shortly. But before we start the alignment check, we have, so the basics of alignment check is we want to make the prerequirements or prerequisite for alignment testing using the cover and cover testing, which is the most formal way and the most accurate way. The patient should be able to see the visual target, the presented visual target in each eye, and they should be able to move their eyes for the eye to take up fixation. That's why we don't start with the alignment in the pediatric clinics. We always start with the vision and then motility to make sure that the eyes can go up and down, right and left, and then we check the alignment. Because you can't do cover and cover test if one of the eyes are not seeing or if the patient can't move his eyes. So vision, motility, and then the alignment. With regards to the motility, we use the H sign. So we will ask the kids, let's say, this is our toy or something. We will ask the patient, like, follow my target, follow my toy without moving your head. And sometimes we need like to like gently put our hand over their head, so we make sure they are not like moving their head. And then we'll ask them, look to the right, all the way to the right, right and up, right and down, all the way to the left, lift and up and lift and down. So we are addressing the movement of the eyes in the on those directions. And if the eyes are moving fully, and if the eyes are seeing, then we can do the cover and cover testing. So with regards to the cover and cover testing, when the kids come to the clinic, sometimes most of the time, when the strabismus start or the sequent or the strabismus or the misalignment, when it starts intermittently and then becomes like constantly. So most of the time, like we will hear the parents, they say that when my child getting ill or like at night when they are like fatigued, they will like one of the eyes will start wandering. And sometimes like it will go out, and sometimes they will tell you like when he focuses his eyes turn in. So most of the time the misalignment of the eyes start intermittently, and with time progressing, it will progress into constant manifest strabismus. Our goal is to be able to pick it up early on so we can intervene. So for the when the eyes come like this, no manifest strabismus, we do the cover and cover testing. So we cover this eye. So for the hidden misalignment part, we look for the eye under the cover. Sometimes the cover can be not totally opaque. You can see through it. And if it was totally opaque, then you will notice the movement of the eyes when you remove the cover. So these eyes are perfectly ortho or straight. When we cover this eye, you can see under the cover that it is moving inward. Okay. And we remove it, you can see that the eye is taking up fixation, is moving outward. So this tells you that this eye or this patient, left eye, when, this is the right eye. No, left eye. When this patient fixation is broken, the eye tends to deviate inward. So he has or she has esophoria. Phoria, a tendency to deviate, but it's hidden. It's not like manifest. Okay. So when we break binocular conditions, or when the child is distracted or fatigued or ill, his eye will tend to go inward. Some of them, it will tend to go outward. So this, we call it esophoria. This is esophoria, and this is exophoria. So eso means inward deviation. Exo means outward. And for the manifest part, we cover, so there up, you can see that the eye here, like the pupil here is looked central, and here it looks like inward. So this is manifest sequent or tropia. Tropia means like manifest strabismus. Esotropia, so the eyes manifestly, one of them is turning inward. And when you cover this eye here, the right eye here, the left eye tends to go outward to retake fixation. Down here, I don't know if I can use can you see the? Yeah. So down here, this eye is ortho, it is in the middle, and this eye is outward manifested. You can see that this eye is outward. So when we cover this eye, the other eye moves inward, and we call that exotropia. So there is tropia and there is phoria. Tropia is manifest strabismus. Phoria is hidden or latent strabismus. And with the cover and cover test, we able to check for them both. For the cover part of the test is for the tropia. The uncover part of the test is for the phoria. And when we do the alternating cover and cover test, we are doing them together, the tropia and the phoria. So if the child can't move his eyes, whether it's neurological condition, muscular condition, or if the child is having one of the eyes non-seeing eye, whether it's related to amblyopia or related to other organic eye pathology, we can't rely on the cover and cover test or the alternate cover and cover test. We can't rely on them anymore. We will be using other stuff like Hirschsprung pin light testing. So with Hirschsprung pin light testing, the idea behind that is if you shine a light from arm's length from the child, if they are ortho, you will see the corneal light reflex in the center of the pupil in each eye. But if one of the eye is deviated, manifested deviation, then you will see that the corneal light reflex is either deviated nasally or temporally. So in this case, the eye is inward, so it's esotropia. And here, okay. So based on the amount of the deviation from the center, we can quantify the degree of the deviation. Roughly speaking, like if it was like 1 millimeter difference from the center, like it is not in the center, but deviated 1 millimeter, this is 15 prism diopter. If it's 2 millimeters, this is 30 prism diopter. This is rough estimation. And we can make sure by using the Kremschke, which is basically we will put a prism over one of the eyes and tries to neutralize the angle of deviation and getting a symmetrical corneal light reflex in each eye. This is another way. Kremschke and Hirschsprung pin light testing is the same, except for Kremschke, we can quantify better, more accurate, because we are using neutralizing prisms. We are not just guessing. And okay, so I know it was like a long talk. I hope that I was not like fast. So do you have any questions? And you must have. Yes, Destiny, go ahead. We see you.
How do you know if it's strabismus or pseudostrabismus?
That is an excellent question. Thank you for bringing it up. So excellent. So the thing is with the pseudostrabismus, it's basically like not a true strabismus. It's just like the eye appearance. It looks like the eye is looking inward or outward. It is related to anatomically. Like sometimes the kids can have like epicanthal fold, and it might give the appearance, the false appearance of esotropia. So we can know that through the cover and cover testing. So if you shine the light, you will see that. And if you shine the light, you are not supposed to see that, you are not supposed to see that the corneal light reflexes are not. But the most accurate way is to do the cover and cover testing. If you did the cover and cover testing and the eyes are not moving, then this is pseudostrabismus. But by the look, by the appearance, you will see, like you will, because of the thick epicanthal fold, you think that this is like esotropia, like the eye is going inward. And sometimes with other conditions, we can have like pseudo XT, but it's not true XT. So when you do the cover and cover testing, the eyes are not moving. Okay, other questions? Okay, thank you. So can you please do the poll test? Thank you, everyone. But we have to do the poll question, like, yeah. And I can click on the result.
Wait a minute. So I question that.
Okay. I am happy. Most of you are getting it right.
Sounds like, because it doesn't say corrected enough. I know.
So just to wrap up and talk about the takeaways. So strategies to improve visual acuity testing in children and in general vision testing in kids. Build rapport before starting the test. Use age-appropriate charts and matching games. Keep sessions short and engaging. Use positive reinforcement and repeat testing when results seem inconsistent. And thank you, everyone. Thank you for listening.
Okay, this year's keynote presentation, which is the last presentation of the day, is a tandem talk from Dr. Scott McCrae and Dr. Ken Dickerson. This is an incredible team at the core of our advanced mission to advance vision correction, helping people achieve their best visual outcomes through corneal refractive procedures. I personally had the pleasure of working at the center many years ago. I'm proud of the great tradition of patient care that has been there for over 20 years. Quick story, many years ago when I was early in my tech career, was working in a general clinic and saw this journal, big journal with a guy on the front of the cover. Kind of looks like that guy on the left there. And it said supervision and basically had all this. And I was at the time pretty skeptical of refractive surgery. But I read this article from this guy and I'm like, wow, this is incredible where things are going. Literally, I don't know if it was weeks later, but I'm told this guy's coming to Rochester, New York to work at U of R. And I was like, no way, I'm going to work for that guy. And so after some, series of things, we ended up working together for many years. And it was what an amazing experience to see the progression of refractive surgery and just the work that's been done there and carried on with Dr. Dickerson. It's just pretty amazing stuff to see lives changed like overnight, literally. And it's been pretty incredible. Dr. McCrae is one of the world's few corneal specialists who had completed 3 fellowships in vision correction and is among a handful of cornea and refractive surgeons who have received both the Jose Barriquer and Lons Awards from the American Academy of Ophthalmology. He completed much of his training at the University of Wisconsin and the National Eye Institute before distinguishing himself at Oregon's Casey Eye Institute. After this, he came to Rochester to collaborate with David Williams to create and patent customized laser vision correction. Dr. Dickerson is a native of the area who studied at SUNY Geneseo for his undergrad and at the New England College of Optometry for his doctorate degree. He is a leading expert in diagnosing and treating refractive error, as well as dry eye and other anterior segment conditions. Recently, they have become one of the nation's leading centers for treating keratoconus, and they'll show you some of the work that they're doing today. So I'd like to have you welcome them as they talk about diagnosing and treating keratoconus.
Well, I'll be starting things off. Thank you all for being here. It is definitely a little hotter over in this conference room. We're going to get through this, right? Because I believe we are the last thing keeping you from going home, right? Unfortunately, Gary's talking a lot about all the things we do to produce supervision. Decidedly, these folks that we're going to talk about today do not have supervision. So that is unfortunate, but it is something that we have learned a heck of a lot about, and there's something we can do to stop it. So how many of you think that as you sit here that you might have a risk factor for keratoconus? Okay, I see most of my techs raising their hands over this. They know a thing or two about this. That's great. It's a heck of a lot more common than we thought it was. Okay, 1 in 344 to 1 in 435, depending on which studies you look at. That also changes or differs across different countries as they look at things. And some of the early signs of keratoconus we look at: changes in prescription, wild increases in cylinder, big shifts in the axis of that of the astigmatism, reduction in best corrected vision. We get some inferior steepening when we look at topography. We get some distortion in our Myers. We get scissoring reflex for those that know how to do retinoscopy. And then the last big early sign, they rub their eyes. So, poll you again. Who's ever rubbed their eyes? Who thinks they might have a risk factor for keratoconus now? Okay. So some of the late changes, a lot of these involve the cornea and what changes we get there. Do we get a Fleischer's ring? Do we get Munson sign where the cornea is distorted enough it actually changes how your lid margin looks up against your cornea, okay? And then my quiz question for you all, the oil droplet reflex, also known as Charlot's sign. Quarter of you got it right, congratulations. Yes, I was being extremely esoteric on that for fun. Apologies, those corneas can also then proceed to get scars, and then they can get hydrops or bullous keratopathy, where they basically swell and fill with fluid. Those are very painful eyes. So those are all the things that can happen. And the question is, what are we doing about it? Who's looking at this stuff? How long have we been studying this? So crank on to PubMed, type in keratoconus. You're going to get 10,804 articles, starting back in 1898. Okay. The other field we're looking at, how long have we been studying eye rubbing? Not as long. Okay, since the 60s. All right, with 312 studies on eye rubbing and your corneas. Okay, so that's the big rub with all of this is it's going to create some problems for you. Okay, now there've been, this is the CLEC study. And basically you take a whole bunch of folks and you say, okay, what happens over an 8-year period of time? Guess what? They get worse. That fits with keratoconus. It's progressive. If they started off worse at the beginning of the study, they had an increased chance of getting scarring to their cornea, which is certainly going to lead to reduction in vision. Interestingly, only about 15% of these folks had a family history of keratoconus. So most of these cases we're dealing with a patient that they're the only person in their family that's been diagnosed with keratoconus. Okay. And so that can become very new for all of these folks. Back in 1976, basically they're looking at rubbing and said no significant psychoneurotic factor. So basically they're like, all right, these people do rub their eyes, but we don't think there's really anything going on with it. We fast forward to 2005 and highlighted early identification and intervention of modifiable behaviors, eye rubbing, especially in young patients, yields the most significant therapeutic effect. So I don't have to do anything other than find an early keratoconic and tell them, don't rub your eyes. And I will have a better therapeutic effect than most of the other things that we have, okay? That's how risky it is. Don't believe me? Watch this. So if anybody wants to scan this, you can go to this website. But these are the folks that decided to, yeah, I want to continue. Please let me continue. Oh.
And one comment that 15% of patients have a family history of keratoconus. So when you're counseling patients, a lot of times these are young people at the beginning of their productive life. And parents, I always say to them, you've got a 15% incidence of keratoconus that we see. So, you know, if you have brothers or sisters, you know, and they're getting into that puberty age group, then you should start looking for that. So the corollary is that most people don't have a family history that develops keratoconus, but on the other hand, 15% do have a family history. In other words, there are families that actually have keratoconus. We saw one family from Yemen where in the Middle East, keratoconus is more common. We saw a 20-year-old that we treated, and then her 12-year-old sister, when we brought her in, and a brother, all three of them had keratoconus. And the reason that we got that is I told them there's a family hit. If there is a keratoconus, there can be a family history that is strong enough that you're going to see sequences. So you want to be suspicious, even in other family members, if they start developing a lot of astigmatism. And Dr. Dickerson's going to go into that.
Yep. This is what happens when you give a bunch of scientists some fancy toys and an interest in keratoconus. Okay. Does any of that look good? Oh, how bad do you think it is, though? How about we look behind the lid? So these folks took a functional MRI, of what happens when one of their colleagues rubs their eyes. So think about all your ocular anatomy. And watch this next part very carefully.
Oh.
Think eye rubbing's innocent now? Like, oh, don't rub your eye, right? And we're not just talking about keratoconus with these. In the next portion, you can get glaucoma from doing this. You can get a hyphema. Your lens can get subluxed. Basically, it moves retinal detachments. All those things have been published with chronic eye rubbing. So we're not just talking about limiting the risk factor for keratoconus with these folks, okay? But I thought that that was fascinating that they were able to show that, okay? Yes.
Gentle eye pressure.
Gentle eye pressure is okay. Yeah.
You can gentle eye pressure for mascara, but never directly on.
So happens all over the place. Okay. These are some folks that you may know of. Steph Curry, pretty good basketball player, got keratoconus. Okay. Mandy Patinkin. I'll try not to do Princess Bride quotes. Okay. Had a corneal transplant. Okay. Jerry Stackhouse, not sure exactly what he's been treated with, but we do know he's got keratoconus. Brandon Williams, cross-linked. Okay. Lewis Holcomb, famous bobsledder, he's probably one of the first ones to come out and really publicly discuss having keratoconus, what it was doing to his vision, and the treatment that he had. All successful, which is great. So this affects everybody. Now, when you're seeing a patient in clinic and you're refracting them, good time? No. All right, so I present to you one of my best life hacks for figuring out what the axis is as these patients progress to more and more irregularity, okay? I've got a red line drawn here, okay? That is basically if you've got a topography free in front of you and you're lost, your autorefraction, you threw that up in front of the patient, they saw 2400, you're like, uh-oh, all right? What generally happens is there's a difference in where they're gonna take their axis and what you're going to measure their axis at, okay? And it's all because of how steep this bottom portion is. So basically, quick and dirty is take a pen, that right like where that red line is, imagine that's a pen. You lay that right across there, think about putting your axis there. Because your topography tells you it's at 54 or 154. You try those, doesn't happen, not getting anywhere. You've got varying levels of astigmatism. You got 1.77 by the K. You've got 8 diopters from top to bottom, okay? What are you going to do? Well, we got plus and minus still folks here. So if you're in minus cylinder, put your axis right where you put your pen. All right. If you're plus sill, put it 90 degrees away, split that sill, and you're going to get an improvement. Keep in mind, this is for the ones that are more progressed. The early progression ones, you can usually follow their Ks. All right. See this in a patient. Put that across where the steepest portion is, and lo and behold, it lines up within 10 degrees of what the Ks are. This patient has keratoconus, but they're not at that advanced. That's their left eye. They get to 20/25. All right. How about this patient? They're more advanced. Oh, it's the same patient, different eye. Okay. It's saying 171, saying 6 diopters of astigmatism. Their refraction ended up at 85. So again, you lay right across where that area is, and you're going to get a better endpoint, because otherwise you're just going to sit there and spin the dial, okay? Now, sometimes it's okay to tell the patient to spin the dial themselves, but that creates a little bit of doubt for that patient. Like, why am I? You guys are supposed to know what's going on here. So this is a way that you can kind of avoid that, and you don't have to go to the back room and pound your head against the wall afterwards, okay? So hopefully that all helps speed you up by a little bit in your clinics. But there's been a big shift in our thinking on keratoconus from what we've been doing to what we're doing now. Our old paradigm was figure out they have keratoconus. That's great. Work on visual rehabilitation. Get them into glasses. Get them into contact lenses, whether it's soft, whether it's medical contact lens, or get, do they need a corneal transplant? And the thing is, the corneal transplant doesn't really treat the keratoconus. You replace their cornea, you're going to get some better vision, but they can actually still progress. Fun fact. What's our new paradigm? We're going to discover it, hopefully early. We're going to treat it early with cross-linking to stop the progression. Then we can get to our next steps, okay? So that we can improve our outcome, our longevity, with these patients, okay? We're going to get into why that's important, because these are just forms of visual rehabilitation. Even if we're putting an intact in, if we're doing a corneal transplant, if we're doing a pair of glasses, all we're trying to do is help those patients see better, but we've actually not done anything for the disease, okay? So early diagnosis and referral is very critical for all of these patients, okay? But there's barriers with cross-linking. Cost, not cheap, okay? Health insurance coverage can be variable, certainly was when it was first approved back in 2019. We had to get over a lot of hurdles to get it improved. Early diagnosis, are we catching it? We're getting better, certainly, all right? Is there a fear factor of the patient having surgery on their eyes? Well, yeah, every patient, any patient. And also you're dealing with lots of families that aren't understanding this, because you got one person in the family with us. You're not dealing with large families that all understand this because mom had it, sister, brother, son, all of that. But they do happen. And those families are, once they're educated, they're very on the ball when it comes to that. So let's talk about one of our very first patients that we treated. So this patient came in January 2024. Now, we started doing this in 2019. We thought we really had all of our ducks in a row. She was referred into the Eye Institute pretty quickly. 2200 best corrected vision in the one eye, 2025 in the other eye. Cornea is very asymmetrically thin at 394 and 523. So this is that right eye. That's how progressed that is. So you may recognize this cornea. Okay. This is what an oil droplet reflex will actually look on a topography. You get that full ring, very pinched together in the center. If you look at that with a red reflex, it looks like somebody put a drop of oil on the cornea because it's a small, dense cone. The other eye, not as advanced, a little bit asymmetric, okay, good thicknesses. What do? Clearly, we want to treat the right eye. How about the left eye? Should we treat her?
Raise a hand.
Anybody who wants to treat this left eye? A few? Okay. All right. So there's the question. Do we treat it? Think about the age. It's a 24-year-old for 2200 vision in one eye. Anybody want her to have 2200 vision in the left eye? No? Okay. It's progressed pretty rapidly with this patient. 18 months prior to being sent to us, we have an eye exam that says her vision in that right eye was 20/20. Okay. From 2020 to 2200 in 18 months. Okay. What's the likelihood of follow-up? Well, what factors can involve that? How about this patient lives over 100 miles away? Okay. What's the likelihood they're going to make it back? We are able to treat one eye. We should probably treat both eyes. Okay. Yes. We treated both eyes.
So,
but it took 22 months.
So I've been doing this for a long time. Dr. Dickerson's been doing it for a long time. You have a patient, they have an asymptomatic eye that's with a little bit of early keratoconus. The other eye is already progressed. That patient moves to Arizona. They get busy. Life happens. And then they come back 3 to 5 years later. And all of a sudden they've got 5 diopters, 10 diopters of regular astigmatism. Their good eye is now bad. So the problem is you can't predict. You don't have the crystal ball in terms of being able to predict. So that's why we've gotten more and more aggressive about treating that contralateral eye just to protect them, basically, because they're not going to notice that progression. It's very similar to, a very mild progressive glaucoma where they don't see the damage until it's too late.
Well, these are currently all the companies that are become very easy to work with. Blue Cross Blue Shield being kind of the first domino to fall, the rest really following afterwards. Okay, but from treatment to diagnosis, 22 months, there was a little bit of progression during that period of time. Patient is certainly doing far better, and we did cross-link both eyes because it was important. So I'm going to switch things over to Dr. McRae so we can talk about some surgical aspects of all of this and why, what's behind the rationale for why we're thinking about this the way we're thinking about it.
So one of the problems we've talked about, you want to treat the underlying disease and then you want to do the visual rehabilitation. So there's a 2-step process. So the crosslink, UV crosslinking is actually treating that underlying disease so it doesn't progress. It doesn't reverse the visual loss that occurs typically, but you want to treat that underlying disease so it doesn't progress. Basically, you're protecting the patient, and then you do the visual rehabilitation. One of the problems with visual rehabilitation is that it can masquerade. You know, if you put a scleral lens on, the keratoconus can still continue to progress, and you can masquerade the progression of the disease if you don't treat the underlying disease. So you want to do that in sequence. And that when you do visual rehabilitation, that may make it more difficult to actually follow the underlying disease. Some of the contact lenses sometimes, not that we're against contact lens rehabilitation, but some of the lenses, when you take them out, the contact lens is actually distorting the cornea, and then it takes a while for you to figure out whether there is progression. So, and we can sort of sort through that, but it's important to get that underlying disease treated. So, in order to really attack this problem, it's very similar to glaucoma in the sense that we want to catch it early before there's significant damage. And so when you see a patient with a lot of astigmatism or some asymmetry in their corneas, there are a number of factors. And if you have a K reading of more than 47, if you have more than 2 diopters of astigmatism, or on Ks or refraction, if you have an increase in cylinder of more than a diopter, particularly over a year, you want to take a look pretty carefully and see whether there's some irregular astigmatism. In addition, if the myopic spherical equivalent actually shifts, usually if the patients get more myopic, more than 3/4 of a diopter in 1 to 2 years, then you want to start thinking about whether that may be steepening in the central cornea, causing a rapidly progressing myopia. In addition, when you look at the corneal Myers, you can see that asymmetry either on manual keratometry, if you just have a simple keratometer, if you see kind of an egg-shaped pattern instead of a nice round ring pattern, or corneoscopically, as Dr. Dickerson has shown you, that can be a tip-off. If the best corrected vision doesn't come up to 20/20, and it has in the past, then in a number of these patients we've seen, the patient comes in diagnosed in one eye as being amblyopic, when it turns out when you look at the Myers that it turns out that it's early keratoconic. So if you can't get that patient to 20/20, it's time to look at the keratometry and see if there's a 90-degree shift in axis, or that there's some kind of egg-shaped pattern or irregular astigmatism. There are risk factors for keratoconus. The younger you are, the more pliable your corneas are. Actually, in the old days when we were doing corneal transplants, we thought younger tissue was better. But if you transplant a 1-year-old cornea to somebody, you'll find that the cornea progressively actually bulges because it's so flexible. So as we age, our corneas become stiffer, which is actually a good thing for a keratoconic. The rest of our body gets stiffer as we age. Our coronary arteries get stiffer. That's not a good thing. But in this particular case, age is not your friend. So people that are young that have keratoconus are more difficult to treat. They're more aggressive typically in terms of the progression of the keratoconus than a younger person. In addition, if somebody's a chronic eye rubber, then as Dr. Dickerson points out, those people are at higher risk. And there have been a number of studies basically showing that eye rubbing in individuals can cause progression. We have a young, wonderful autistic girl that we just treated, but she's just chronically eye rubbing. And so we work with mom to teach that child. She's 21 years old, but still sort of young in terms of her development, psychological development. We've taught her to do different things like holding her hand like this, as when she feels like she wants to reach up, just keeping her hands down. And there are techniques that you can use, behavioral therapy, to get people to stop doing that chronic eye rubbing. But just teaching them a different tick that they can do to substitute for that eye rubbing is really helpful. Often these patients have strong histories of allergies. which would explain why they do have eye rubbing. And they can be what we call atopic, where they have chronic sinusitis, asthma, chronic contact dermatitis, vernal conjunctivitis. Those are all people with higher risks of keratoconus, because there is an actual genetic link between keratoconus and allergy and atopism. So if you have a positive family history, we talked about that 15%, you know, it's good to let the family know, well, there's a 15% incidence of this. So, you know, if they have other brothers and sisters, they should probably be looked at with some suspicion that they may be a little bit more likely to develop it and maybe be followed a little bit more closely. Very similar to that concept of family risk with glaucoma. If there's a high manifest refraction, if somebody's really myopic, or if there's more cylinder, as I mentioned, if corneas are thin, less than 470 microns, Down syndrome patients, hyperelasticity patients like Ehlers-Danlos, those patients are also higher risk for the cornea being more elastic and developing keratoconus. If patients have had refractive surgery, now the diagnostics are really, really good. It's very rare that somebody develops ectasia or weakening of the cornea from LASIK or PRK or SMILE. But if they've had that and they start changing, particularly if you see a patient that comes in after they've been stable for, you know, a year or two, and then they all of a sudden have 2 doctors of astigmatism, to me, that's an ectasia or a weakening of the cornea until proven otherwise, in which case we do topography just to make sure, just to rule that out. Now, we talked about the incidence of keratoconus and prevalence. The original study was done by Bill Burns' group. The top study up here was done in 1986, and the incidence was 1 in 2,000. That's what we used to quote all the time. Since then, the topographers have gotten so good that we're now able to identify it much, much earlier. It's very similar to the whole autistic. There was a talk about autism this morning from the pediatric ophthalmology group, and it's very similar to the autistic issue, and that is that because we've gotten better and better at identifying children that are even mildly autistic, you know, the autistic rates have increased. That really explains that. Similarly, we've gotten better and better in terms of the diagnostic instruments in early identification of keratoconus. So the incidence is significantly higher. In Western countries like the Netherlands, it's about 1 in 375. There was another study done in the United States. It was about 1 in 400 at the University of Illinois. But you'll look that it actually is more common in places where there's lots of sunlight. It's not a rare disease. When it was originally approved in 2016, it was considered a rare disease because of that 1 in 2,000 instance. But now we know that it doesn't really fall into that category. It's much more common than we imagined back in 1986. The prevalence of keratoconus, this is a study that was done by Gellis. Basically looking at that, the prevalence was 1 in 344. The keratoconic suspects was 1 in 669. And when you combine all that, it's 1 in 200 individuals in terms of keratoconus. So you're going to see it. The real important thing for you is, can you pick it up early? That's what we're trying to do. What Dr. Dickerson mentioned earlier was that, you know, with refractive surgery, we're changing people's lives. With keratoconus, we're changing their lives. We're literally, I feel really good about treating people with cross-linking because you're really changing the path of their life. A lot of these people, I've treated 150 over the past 4 months, and many of those people are relatively young, and one eye is not good, and the other eye is just starting to decompensate. By treating them, you're altering their path. I've done corneal transplants for many, many years, and that although transplants are really an excellent therapeutic modality, to avoid having them go through a corneal transplant and having the risk of cataract eventually, glaucoma, and having an intraocular procedure. That's a huge benefit to these people. If you can catch them early before they start having really severe, significant vision loss, and treating them early, you're going to change the course of their lives. I've seen a lot of keratoconus where their keratoconus is very advanced, and it really changes their lives. And if we can catch them early at that teen to early 20 age group, get them early, get them treated, you're really doing them a major favor. They don't know that, but I know from 30 plus years of experience that that's really going to change the course of their lives. So the Belgium study basically looked at a large group of patients at the time of diagnosis. The better eye was 51 diopters in terms of Kmax, keratometry max curvature. You'll hear that term Kmax. That's the maximum keratometry reading that you can get off the topographer. 51 in the better eye and 58 in the worse eye. And when you look at this, only 20% had early detection. Now this was done a little bit earlier. I think we're getting better and better, but 80% were detected late. And so with the topographers and with what we have and more education, this has a huge role in basically intercepting this disease at an earlier stage. So this is actually borne out by the incidence of corneal transplants. Corneal transplantation is, keratoconus is one of the most common causes of needing a corneal transplant. About 20% in the old days went on to needing corneal transplants. Now that number is dropping pretty significantly. And this just basically points out that, that we're doing less corneal transplants for keratoconus, basically because cross-linking has intercepted the disease and allowed us to treat before patients go on to being severely visually disabled. So yes, cross-linking rates are going up, but corneal transplant rates are going down. And the PKP in the United States is about 2,000 transplants a year. So this is an example of a patient we saw a while ago. They were evaluated initially in 2022. These were the Ks. They were fit with a Zen lens, and they did relatively well with that. But their vision actually worsened, and they eventually came to us. Because of that worsening of vision, their best corrected vision actually dropped down to the 2100, or the uncorrected vision was 2100, 2200, and they just were progressing worse. And you'll notice that the corneal thickness is 399 in the right eye, 446 in the left. So we went ahead and did a bilateral epithelial off, what we call the Dresden protocol. Now there are different ways to do cross-linking, and the gold standard is basically taking the epithelium off, then soaking the eye with a dilute solution of riboflavin, which is vitamin B2. We take that in every day with fruits and vegetables, but it's just a very dilute solution of that, and it has a kind of a yellowish color. And then we soak the eye for a half hour with drops every 2 minutes, and then we take a UV light and actually put it on the cornea for about 30 minutes. That's the gold standard, and it arrests the progression of the disease in about 95% of eyes. So we went ahead and treated that patient. These are the maps before, and you could see milder keratoconus in the left eye, and some fairly advanced keratoconus in the right eye. We did the cross-linking treatment where we removed the epithelium. We used that dilute riboflavin solution and the UV light. And it's about the same amount of UV light as if you were fishing on the Chesapeake Bay, 370 nanometers. Now, blue light is 400 nanometers, so it's really pretty close to just regular light, visible light. but that it's the combination of the UV light and the riboflavin that actually causes the corneal to cross-link and stiffen. So when you do a cross-linking, as you can see on the right, this is what it looks like. You'll see kind of a yellow-green glow. This is the actual UV light that's shining, and it's got some crosshairs so that you know that you're in focus. And the patient just sits there for about a half hour. The hardest part for the patient is actually the lid speculum, them getting adapted to that, which takes about 10 seconds when you put it in. We use topical anesthetic. The patient, if they have any pain, we just put anesthetic drops in, and it's not a painful procedure. Afterwards, the eyes are scratchy and irritated. We give them some oral pain medicine to get them through that period. But after the first 2 or 3 days, they're comfortable, and usually within a week, they're able to get back pretty much to most of the normal things that they do. So as I mentioned, we instill that the riboflavin every 2 to 5 minutes for about 30 minutes, then expose the riboflavin or the eye to UV light, 370 nanometers. There's a certain amount of energy that we use in terms of the fluence, 5.4 joules per centimeter. And then we put a bandaged soft contact lens on, treat them with antibiotics and steroids, and then we see them the next day. And then we see them 1 day, 1 week, 1 month, 3 months. Usually after 2 to 3 weeks, they can get back into their contact lenses. Once that surface layer is healed, the corneal epithelium is anchored well. So, well, how does this actually work? Well, the riboflavin and the UV light cause a photooxidation, which creates a reactive oxygen species. And the oxygen actually excites and then goes down, up and down. There's actually now a pulsed UV light that is often used, and the light goes on and off. That allows the oxygen to excite again or come back down, and then get excited and come back down with a pulse system. But those are sort of technical details that you don't need to worry about. This allowed the corneal collagen to form cross-linking on the surface of the collagen fibers within the proteoglycan coating that surrounds them. So this was the original Avedro study. I actually sat on the FDA panel with 11 other panel members reviewing this data. I was a primary reviewer back in 2016. And those results were impressive. The keratoconus was arrested in almost all the patients, while the control eyes, there was basically a crossover study where one eye was treated with the riboflavin, the other eye was observed. And then after 6 months, if there was, if this eye was stable and there was progression in that eye, then they could treat the second eye. The Kmax, that steepest part of the cornea, the Kmax, was improved by 1.6 diopters. In other words, the cornea actually flattened that amount. In addition, the Kmax improved by 2 diopters in 30% of eyes. That tended to happen in younger eyes. They're a little bit more pliable, and so you'll get more response from them. The Kmax decreased by 2 diopters in 5% of eyes, and some of those eyes actually broke through. So I said that it's 95% effective, but about 5% of patients will go on to get worse. Usually it's not dramatic right away. So these patients need to be followed. So I tell patients, once they're diagnosed, they need to be followed pretty much for the rest of their lives once a year, especially if they're young. If you're 70 years old and had a really mild case, not very likely for it to progress. But the young ones that we're probably going to be, most of you are going to be dealing with, those people need to be followed, and preferably by a group that can actually do a good topography to follow them to make sure that they're not getting worse. The Kmax improved by 2 diopters in 30% of eyes, decreased by 2 diopters in 5% of eyes. And those eyes could be retreated. And Dr. Dickerson and I have had a number of patients where they've come back, they've actually gotten modestly worse, but then we went ahead and retreated them. We've not, knock on wood, we've not had any of those patients actually progress. And we've literally treated hundreds and hundreds of patients. In other words, you can treat this disease. It's not like they're going to progress and go blind and need corneal transplants. This was a study that looked at 20 eyes in terms of minimum corneal thickness. They found that 320 microns was the minimal corneal thickness. There are actually people that are treating some of the groups that originally treated this was developed in Germany. Some of those groups have treated thinner corneas. They usually modify the treatment, so it's sort of a milder treatment, so it doesn't damage the endothelium, the corneal endothelium. When you look at the literature, there's actually no reports. We've always worried about damaging the endothelium, but there have been thousands and thousands of treatments with keratoconus, and there are no reports of basically the endothelium decompensating from a UV crosslink. But we're always kind of concerned about that. And when the cornea gets too thin, usually those eyes are so advanced that a number of those eyes are going to require a corneal transplant anyways. So if the corneas, there are two different solutions of riboflavin. One's kind of a jelly-like viscous that has some dextran in it, and the other one is basically a non-viscous solution. If the cornea is thinner, we use the non-viscous solution that actually swells the cornea so it gets up to around 400, and then we go ahead and treat at that point in time. So as I mentioned, the endothelium, the corneal endothelium doesn't seem to be as susceptible as we were initially concerned about. And using the less viscous solution, the cornea can swell about 100 microns. So one of the studies that was done is called the Sienna study that looked at pediatric cross-linking. These are the patients that we're really, really concerned about. These are the ones that once you get into the pubescent age group, anywhere from 10 to 18, that's when you start seeing progressive keratoconus, and it tends to be more aggressive in those individuals that present early. When they did that, they noted rapid functional improvement after cross-linking and better long-term stability, irrespective of corneal thickness, in about 80% of patients. Patients with thicker corneas tended to do better than the thinner ones, and we've seen that in the adult age group as well. But the bottom line was that there was a fear of treating young people. Now I don't, if I see a 10-year-old that is got keratoconus, even though the FDA labeling doesn't say you can treat it, from my perspective, if it was my child, I'd want to treat it with cross-linking. So in terms of post-cross-linking care, we allow the patients to return to their contact lenses as early as 2 weeks. The subtle corneal changes can continue to change for 6 to 12 months. The corneas actually get a little bit worse. The vision, if you look at the data closely, the vision actually gets a little bit worse that first month. The cornea actually can swell a little bit, and then after a month, the vision actually can improve. And in the original study, the Avedro study, the patients actually gained a line of vision. But I usually don't tell the patient, you're going to gain vision. This is not going to reverse that. Most of the time, the line of vision that they gained was on average for a large population, but the patients don't really notice that. It's a pretty subtle change. So I don't emphasize that you're going to gain vision with the procedure. I emphasize that we're doing this to arrest the process, not to reverse the process. You just don't want to set those unrealistic expectations. So as I mentioned, the keratoconus can recur in 3 to 5% of eyes. It tends to happen in younger eyes. The steeper the corneas, the more advanced the keratoconus, and those eyes are more risk for recurrence, as well as atopic individuals or patients that are eye rubbers. This can be successfully retreated, as I mentioned. So we just go back and do another treatment. So this is an example of a patient that was treated at a really high quality group at the Cleveland Clinic. They do a lot of good work on ectasia. They were treated with the gold standard, Dresden protocol with the epithelium taken off. They were diagnosed with the keratoconus a year and a half previously, treated at Cleveland Clinic, had a positive family history, younger siblings diagnosed in 2021, and noted that their vision started to decrease again but the other eye was doing okay. This is the right eye. You can see that asymmetry. I find the Myers are actually pretty helpful in looking at these. And you can see what the patients are actually seeing, how this could be really, really distorted. You can see the corneal topography pattern where you see that steepening centrally. This is after treatment. So, so that patient was retreated, basically stabilized and did well long-term. So there are a number of tools for diagnosing keratoconus. You are all important tools. You're probably the most important tool for diagnosing, because if you do the topographies and you have that level of suspicion for your patients, then it can make a big difference. So you want to jump in?
So can't tell you the number of times I've had a tech come up to me, hey, the Myers look funky on the autorefractor, right? Just the autorefractor. You didn't even get to the topography. So something as simple as that, it looks funny to you, you should be telling your, tell your doc, okay? And that can be extremely helpful. But we've got lots and lots of different tools. As we've been showing you lots of placido imagery, there's different formats that have grids to create that topography pattern. We've got OCT and we've got our Scheimpflug imagery. We've got some that combine multiple aspects of these, but these are just really become very sensitive tests so that we can figure out whether or not somebody's got keratoconus. And what we're looking at is we're looking at creating a map of the front surface so that we can figure out, is it normal? Is it not normal? Well, the question is, what's normal, right? All right, so we got A, B, and C down here. Who's concerned about the one all the way to your left? Thank you. Anybody, the second one, worried about that one? Okay, how about the third one? Okay, how about this one?
Yep.
Okay, the only one I'm not worried about is this one. Okay, because it's steeper on top. That's most likely a tight lid. Okay, young person with a tight lid. All of the other ones are actually very suspicious patterns. Call these lazy eights. Okay, they look like eights, but they don't look right. Okay, think about it that way. So there's lots and lots of information that I'm not going to bore you with on these, but we're looking at the amounts of astigmatism, how regular the astigmatism is, and a lot of this comes down to pattern recognition. Does it look normal? Okay, what do you think? Does that look normal? Top should look like the bottom on when you're looking at a scan. If the top is green and the bottom is red, red flag. It's not supposed to look like that. Okay, and it can sometimes be as simple as that. So we look at all these different values. Inferior to superior, what's the actual amount difference? Is the central case deeper than 47? Keep that number in your head, 47. If it's deeper than that, there's a red flag. How's that thickness? Okay, now I realize not all of you are measuring thickness on a regular basis, but the thinner the cornea is, the bigger the risk factor. Okay, these are basically some normal topographies. That person's probably just got some spherical nearsightedness, farsightedness, very little astigmatism. This one's got a lot of astigmatism, but their astigmatism goes top to bottom and it's very symmetric. That's normal. That's okay. Again, we got normal. We got a little suspicious. We get one of those little lazy eights, and then on the bottom, we got real abnormal, okay? And you can tell that big difference. But how about this? I've seen patients where this has been their progression, okay? So this is the first visit that they saw with an eye doctor who was fitting them with a contact lens. They did fine, came back, they're looking like this, and all of a sudden, 12 months later, they look like this. Okay, and that progression can happen that quickly. So all of these are asymmetric. Okay, highest suspicion, not as high, not as high. Okay, it just basically progresses from one side to the other, but all of them should raise a red flag of, that doesn't look right. Okay, and then we can get even more distorted when we get even further down. So this is a pellucid patient, so their steepening is even off the map. It won't even read it. Whereas keratoconus is kind of that mid corneal steepening. Okay, so there's just basically different versions of what it can look like, but all of these patients have corneal ectasia. And this is more on our lazy eights. Those don't look right. Okay, so if it's skewed one side or the other, that's a very early sign on the topography that it's not going well. Okay, now how about this? If I told you that that inferior to superior, is normal, right? So from top to bottom, we look at that, it's normal, but it's normal because we're not looking in the right spot, because this patient's astigmatism isn't in that area. We look across there, then all of a sudden that becomes a different view. So sometimes we can't just be concrete and be like, oh, inferior to superior. Sometimes you have to rotate it based on what the patient's cornea is looking like, okay? Then there's the D value. So how many of you do pennicams? Okay. So if you have a funky looking topography and you want to give your doc a scan that's going to help them out the most, give them the Bellini scan, because it's going to have a D value down here in the corner, and it's going to come in different color schemes. Guess what? Green is good and red is bad, and yellow somewhere in between. Okay. And it'll highlight that for us. And so as a provider, I can look at that and be like, red flag, because we've already marked these out to say what's normal and what's not normal. Now, this is a patient that we saw 2 days ago. Right eye has keratoconus, left eye is suspicious of keratoconus. And all we have to do is look down at the bottom. We look at one number. We can look at the D value. It's over that 1.5 units, and all of a sudden we get suspicious. Okay.
Ken?
Yep.
So yeah, if you have pennicams, I actually talked to an optometrist today from our group about the D value. If it's like over 2.4, you should have a really high level of suspicion. The color, this lower right D value is the one. These are D value for the front,
the back,
thickness,
mm-hmm.
And another fudge factor. But there's actually 10 numbers that are going into this. It's like a artificial intelligence type thing, where they look at all these different variables and then kick out this number. If that number's kind of red, or 2.5 or something like that, then you should start really being suspicious. So one other quick thing is that if you have a lot of asymmetry on a topographer and the other eye is normal or whatever, it's really important that when you do a topographer, that to make sure that they're centered. If the patient happened to look off just a little bit to the left or right or up or down, you're going to get something that looks like keratoconus. So if you suspect that the patient's not cooperating well or not really good, then just take another scan and make sure that that's not an artifact, that's really a keratoconic. So
yeah, I'm not going to yell at you if you give me 2 scans ever.
Yeah,
I took a couple more scans, doc. No problem.
Actually, now we do a Galilei. This is a pennicam, but we do a Galilei and a pennicam. And that's really helpful for me to make doubly sure. If you see a normal on the pennicam and then an abnormal on the Galilei, well, it's like, well, I want to have I want a tiebreaker to basically see, is that real or is that just a decentered scan? So decentration is actually, your centration is really important to giving us good information. I'd hate to treat somebody with, cross-linking, have them go through all of that just because we had a decentered scan. So that it all has to kind of fit together.
And that's why I said you guys are one of our most important tools for figuring all this out. It's a team effort. So here's a 27-year-old male. Got pretty high levels of myopia, got pretty good pachymetry, doesn't look really all that funky. When we look at those D values, there's a little bit of change from one eye, but then, a little bit hugging that bottom portion, but then this one goes way under, and it's driven by that inferior steepening right there, which is a little suspicious. And so this is a patient we're just going to follow because it doesn't quite fit all the characteristics. We still got good vision, but this gives us enough suspicion to say, hey, let's see you back in 6 months. Don't rub your eyes in the meantime, and we'll see what happens, right? So what do we need to make sure that we're doing? We got to counsel these patients. Our goal is to halt the disease. We want it to stop. We don't want it to progress. Unfortunately, we don't have a cure. We're not curing this, but we're stopping it because keratoconus is not going to cause a patient to go blind, but it is the leading cause of legal blindness. Remember, there's a big difference. They're not going lights out, can't see anything, but visually disabled, can't see well enough to drive, can't see well enough to do a lot of things, need to have glasses with a scleral contact lens, with all of these things. In their lives, quality of life, it's a huge hit, okay? And then, of course, the earlier we get them, the earlier we treat them, then more successful we're going to be on the end. Okay. So again, we've got many different forms we can get them better, but this is how we really actually stop that progression so that we can improve it. All right. There's lots of different studies that have gone on with what can actually make it better. Hard contact lenses, scleral contact lenses, those modalities do tend to work the best, but the sooner we get them, the easier it is for us to use any of these, whether it's glasses, whether it's soft contact lenses. So that's where early intervention is important. Let's just spend a moment on Intacs, on basically you're putting an intercorneal ring into the cornea, so that actually is put into a tunnel within their corneal tissue so that you can flatten the center of the cornea. So you see these every once in a while. You take an image and you ever see one of these half moons. Sometimes patients will just have one end. A lot of times they'll have both. I just want you to be aware if you're looking at a patient's eye on any scan, those are pretty normal. So they actually make a tunnel and then they actually bring that in. Now that we have plastic ones that are PMMA, and then we actually have ones that are harvested tissue that's been sterilized so that it can go in there less rejection from the patient with those. And then we have our other surgical treatments. We've got penetrating keratoplasty, that's your full corneal thickness transplant. Then you've got your deep lamellar keratoplasty where you're just replacing about 95% of the corneal thickness, okay? These can still be cross-linked. Keep that in mind, okay? If somebody gets to that point and they still have progression, you can still go back and cross-link them and give them an improvement in their vision. So again, early suspicion, early diagnosis has really helped us with this paradigm shift of going from just getting to try and see better with glasses, contact lenses to let's treat it, let's stop it, and then let's get on to doing all the rest of that. So we've just really kind of flipped that in there. But our treatment modalities, our options are much, much better than they were. Our therapeutic tools are so much better than they were. And what does the future hold? Currently, we're using Photrexa, which is the epi-off. Questionably going off the market in 6 to 12 months to be replaced by Epioxa, which is epi-on, which should garner approval in 2025. The only concern that we have on our end is it may not be as effective, so it's going to be more important for us to catch these patients earlier. We get a little bit less flattening of the cornea. We haven't yet seen that improvement in vision. Again, with that, but that looks like that's what the future holds for us. But then that brings us right back full circle to one of my earlier slides that leaves us in the same boat. We're going from epi-off to epi-on. What do we end up with? Well, we end up with what's the cost going to be. From all of our understanding, it's going to be a substantial cost difference from where we are to the new procedure by a pretty large magnitude, which is going to put us back to where we started with having to work with our health insurance companies to get things approved at a level where it's cost effective. But again, we get them early, we get those patients referred in, they're going to do better no matter what. And again, we always have to deal with these last two aspects of patient care, which is a good thing for us to be able to do and to be able to explain this to the patients because it's their eyes, it's their vision, and long-term wise, we want to preserve their vision, okay? Thank you. I will point out with 1 minute to spare. Anybody have any questions?
So you gonna do it? So we turned the
yes.
Yeah.
There you go.
So this is a difficult time for us. Basically, it's the best of times, and it's yet a challenging time. So the Dresden protocol, the epi-off, we take the epithelium off. The visual recovery usually takes a week or two. Patients are more uncomfortable with that. But when we look at when I actually sat on the FDA panel and got that approved, we looked at that data, there's about a doctor and a half of flattening with the epi-off. Whereas with the epi-on, which is the new Epioxa system that Glaukos is promoting, there's only about a half diopter, about 1/3 the corneal flattening, which is, you want corneal flattening. So this is it indicates to me that this is a more potent treatment. In addition, there was a line of vision improvement in that we mentioned that before. There's a line of vision improvement in the Photrexa treated group, the epi-off group, which is the gold standard, which is what we've been doing since 2003. We know that that works. The problem with the Epioxa issue is that there's no visual improvement in terms of that group, so it doesn't seem to be quite as potent. Other problem is that the company is, when this was first approved, they charged $800 for this. It was that company got bought, and then Glaukos bought them, and now they are charging about $4,500 for the epi-off, which you can make riboflavin per eye. Yeah, which you can make for $300 basically, but they're charging $4,500. With the Epioxa, they now want to charge $78,500 per eye. Okay, that's a 17-fold increase. So, but the company's strategy is that we're going to advertise this kind of like you would do with Humira, when you watch the NBA playoffs or whatever, 60 Minutes. They have all these commercials. They're going to promote it. Their objective is to get as many people treated as possible. They actually have a good message: catch them early, treat them early. But they also have this massive increase in price, which a lot of cornea specialists are very upset about, to be honest. And we don't know exactly how this is all going to play out. We're still trying to figure out what's the best strategy to get patients access. And meanwhile, we don't know how the insurance companies are going to respond. Because when you're cranking the price up from $4,500 to $78,000 per eye, it's almost $80,000 per eye, $160,000 per patient. And then if you have to go back and retreat, it's like a lot of money. And it's not kind of like this orphan, it's not the orphan population that originally, when we looked at it in 2016, we realize now it's a much more common thing, and there's going to be a lot more people properly needing treatment. So it's a complicated answer, and it's a sort of a dilemma that we're going to have to fight our way through.
We're not sure. We don't know the answer to that. But the other answer of what's the difference? Your epithelial layer is a barrier to any drug. Okay, so any drug, whether it's a glaucoma drug, an antibiotic, whatever, that's got to get into the eye, it's got to be specially formulated to get through your epithelium. It took them a long time to figure out how to formulate riboflavin to actually penetrate through that barrier. Now, obviously, there's patient differences. Every patient's epithelium is a little bit different, a little bit thicker, all those things. So those factors can also be leading into why sometimes we're getting these differences in how effective the treatment is. So with the epi-off, you just remove the epi, it's out of the way, and you don't have to worry as much. You can use a much bigger molecule, you can get more into the tissue, and that, easily a better treatment. But they have figured out how to get it through the epi, which is an improvement, certainly.
If you look at I've looked at the data extensively. If you look at the data, Epi-on it just doesn't seem to do as well. There's only one other Epi-on that seems to be better. It's called Epi-Smart. That may be approved in another year or so in the United States. But when I look at these two, I think that, Photrexa, the Epi-off is sort of the gold standard. If you have a young person that's 16, in an aggressive keratoconus, that's what I would want to have them treated with. The Epi-on, probably for a 45-year-old with mild keratoconus, that might be a really good, appropriate treatment for them. So I don't think that one size necessarily fits all, but, our hands are kind of tied by the strategy that the company's using. There may be some availability of the Epi-off. They're kind of trying to hide that, I think, because they don't want the insurance companies, they want to come with this new product, and they just want to say, look, we got this new product, it's new improved. They don't necessarily, the insurance companies don't necessarily look carefully at the data, yet, they want to basically make a good profit on it.
Other questions? Yeah, sure.
Leads you guys just, what's your approach to form fruits? Are you proactive and do the cross-linking? Do you observe?
So with form frus, that's, kind of like your preclinical by definition keratoconus. We're highly suspicious of those. We do monitor them very closely. There have been some, there's certainly aspects where you have a patient that so aggressively has progressed in one eye and the other eye does appear to have very early signs. We treat it. Okay. But there are some, they come in and it's just really put them on a situation where you monitor them closely. Right, you give them the information. We know from our studies. If you simply get them to stop rubbing their eye, their likelihood of progressing went way down. Right, if they're an eye rubber and they're sitting in your chair and everything looks funky and irregular, you get them to stop doing that. You did really a good thing that day. Right, so
age, if they're young, allergies. If they're 70 years old and they're form frust,
yeah.
I'm not so worried.
No.
But if it's 15 years old, then then we want to watch it really close.
Thank you very much.